for the integrated care system through from 9 to 11. And we're also welcoming my dog, if you can hear it, and we're also welcoming Emma Wimpress, who's our newly appointed head of volunteering across the group, who's already done a pretty good job in raising a number of volunteers, but lots more to do. And we're also joined by Mara Tonks, who's head of midwifery at KGH, who is becoming the head of midwifery on an interim basis at NGH for item 10. So, patient story. It's a discharge programme story, and there was a mandatory national call last Friday about primarily about ambulance handovers, which are clearly a major issue across the NHS in general. We're not in a terribly bad place in Northampton or Northamptonshire even, but we do have some erratic performance in ED in terms of ambulance waits. But of course, the focus rapidly turned to the discharge processes. And it can be quite tempting sometimes when we think about the discharge process to think about all the out of hospital things that have to happen. But actually, there's an awful lot we should be doing better if we were really aiming for a top-notch discharge process in the best interests of our patients, because we all know that staying in hospital longer than you need to is a bad idea, and certainly has detrimental effects for patients. So, intros today from Debbie Shanahan, Interim Director of Nursing, who's somewhere on my screen, I'm sure, and Palmer, who's our Chief Operating Officer in Northampton, and there's some videos to run of this as well as they talk about patients. So over to you guys.
Thank you, Chair. Good morning, everybody. As you know, my name's Debbie Shanahan, Interim Director of Nursing at Northampton, and the patient story that we are about to show you is about the patient's experience of her discharge from Northampton General twice. Other than that, over to the actual video, unless Palmer's got anything he wanted to say.
Get myself off mute. No, I think the video was great.
Hello, my name is Katrina Labram, and I've been invited to come and talk to you about my recent discharges from Northampton General Hospital. Before I go any further, I'd like to say that the care I received whilst an inpatient was second to none. And also, having worked as a nurse at Northampton General for over 30 years, I do feel it's very disloyal for me to say things that are negative about the trust. But I realise that the only way the trust can learn and develop is if people are honest. I was admitted twice during August and September with COVID pneumonia. The first admission was to Beckett Ward, where I stayed for approximately 12 days, and the second was to Hawthorne, where I was an inpatient for about 6 weeks. I believe that the issues surrounding my discharge were the same from both wards, so I will put them together, basically. The main issue, which, as I'm sure you're all aware, is waiting for your medications to be brought up from pharmacy. As there's no visiting on COVID wards, you can't ask your relatives to come in to collect you until everything is ready on the ward. My son booked 2 days, both days that I was due to be discharged from work. As an HGV driver, he doesn't get paid if he doesn't work. So he sat around all day, and I wasn't discharged until late afternoon, early evening on both occasions. So he lost 2 days' money. Once my tablets had arrived on the ward, nobody actually went through them with me. I wasn't told. I knew that I'd been put on a Pixiban, but I wasn't told how long I had to stay on it for, whether it was just the month that they'd supplied, or anything about my change of medication. I was discharged both times on home monitoring, which I found to be very, very reassuring. The transition from hospital to home, especially after a long stay and being so acutely ill, can be quite intimidating. The nurse who came and bought me my home monitoring equipment was very good. She went through it all with me and ensured that I knew what I was doing with it, told me what time I was to take my recordings and how to input them, and that the company supplying the equipment would contact me at a certain time the following day to set it all up for me, which they did. They were very, very helpful, very, very patient, and stayed on the phone whilst I did the first set of recordings and put them into the system. It's very reassuring to know that you have somebody that you can contact up until 9 o'clock at night, and I was assured that if I felt unwell after that time, just to send for an ambulance and it would not be an issue. In fact, on my second admission, I was 30 minutes late putting my recordings in, and they contacted me to see if I was okay. The only thing I would have found helpful with the home monitoring service was if somebody in the team could have been a prescribing practitioner, because my blood pressure following my first admission fell steadily. I was on 3 lots of antihypertensive medication when I was admitted, and they were unable to advise me whether to stop them, continue them, so I had to contact my renal consultant for advice on what to do with my medication, and thankfully I am still now on none. As I said previously, the transition from hospital to home can be very intimidating, and it was I felt that I was really well supported when I was discharged with the home monitoring team, and before discharging me from their care, they discussed fully with me that I was happy for them to do this. Thank you for your time. Thank you.
Okay, thank you very much. You guys want to say anything, Palmer, Debbie?
Yeah, if I might just start, I think we know at NGH we have an issue around our discharge, not just in terms of our numbers, which we'll go through today, but also the manner in which we discharge, which the patient story has highlighted. I think it isn't for lack of compassion, lack of care, and lack of willpower that these things are happening. So I think our staff are doing the right things. And I just see through a presentation later, I think it's one of those things where the system and the systems supporting us have not been aligned to get our patients out at the right time to the right places and then give them that right experience on the back end of it. And the classic kind of, if you carry on doing as you've always got, you will continue to get the results you've always got kind of mantra. We've got to try and change how we do things structurally across the whole of NGH, which we'll cover later. But these stories are really useful to hear, both in terms of the anguish we've caused some of the patients, but also some of the feedback so we can make those pathways better for them.
I couldn't agree more, Palmer. We have a lot to learn, and I think the video and the experience highlighted that, but it also will dovetail into the work that the teams are doing. Thank you. I
think if you ever talk to anybody who's been in a hospital, they'll tell you waiting for medicine is a real pain, and it does seem as if it's one of these perennial problems. I think as well, two things that struck me about it. One was the idea that it's disloyal to criticise the hospital is just fundamentally wrong. You'll never get better unless you are honest about what the problems are. And the other thing was that we have been quite enthusiastic proponents of home monitoring, particularly when the pressure's been on. And whilst I'm sure it can always get better and it can broaden what it does, it seems to me that the home monitoring, it must be better for our staff and our patients to know that they can be discharged home while still being seen, and for want of a better word, visible their condition. So, comments, Jill and then David, please.
Thank you, Chair. I mean, yet again, a huge thank you to the patient in the video, because it is quite stressful being videoed and telling a story. And I guess to some extent her loyalty was because she was a nurse at the hospital for such a long time. But Of course, you're absolutely right, Chair, that unless we hear about what works well and what doesn't work well, then we won't improve at a sufficient pace. Really pleased to hear about the home monitoring, which seems as though it's working really well. Not to necessarily to be answered now, but we've got a really good section on discharge later on in the board. And one of the questions I was going to ask was about TTO delays, so medication delays, because I couldn't see anything in the paper about that in terms of actions, but I might have missed it. So it might be a question that colleagues would like to answer when we get to that particular paper.
Okay, David?
Yeah, thank you, Chair. Yeah, once again, I echo the remarks of Jill that, yeah, thanks to the patient, because that's the only way we learn is by hearing from the patients. However, Jill's also echoed my words. I have down here TTO, and TTO, since I became a non-executive in the NHS, which was only 10 years ago, which is a short period of time for some of the people sitting around the screen, TTOs have always been an issue, and it's been something we've never been able to address. And it does, you know, for someone coming from a process-driven industry, it does seem to be one of these things which is rather perplexing for the layman to understand. Why do these things always arrive at the patient late on in the day? So, you know, and we presumably can't fill the bed then, or whatever. But TTOs are one thing, and you can answer that at a later point in the agenda. My second thing was also about the home monitoring, and this is really great that we're doing this. And can I just clarify, was this a Doppler system which this patient was being monitored by? It was the Doppler system, yeah? Yeah, that's good to hear, and it's good to hear that the patients are positive about this. I believe we're now being targeted to have a certain proportion of our patients monitored virtually. Am I correct in saying that? Who could answer that? Palmer? If so, how are we doing against getting to that target?
The system has a target, and I think it's for a virtual wards, I think is the phrase.
Yeah.
I think the important thing is that we don't play games with that target and redefine things that already happen as virtual wards. But I'm sure Palmer can or Heidi can tell us exactly where we are with the numbers for that. Can't you?
Yeah, no, unfortunately, I was just writing down a note on my piece of paper about TTOs, as you said that, to come back to it later, just to repeat the question.
Okay,
sorry.
I'll give you a moment for that. Let's gather your thoughts for that. Elena.
First of all, thank you to the patient who has really made a very valuable contribution to our thinking, and I'm sure that her story will impact on the way how we're working. I would not comment on medicine because, yes, I experienced these delays through my daughter, and it's absolutely shocking when you come from automotive business where everything is planned ahead and really things deliver just in time. My question is about this home monitoring. It really looks like a great program. I would like to understand the scale of this program, how many unnecessary inpatient days it saves for us, and do we plan to roll it further? Thank you.
Okay, thank you. Come back to that. Palmer's working it all out avidly. Karen.
Thank you. I was going to answer a couple of questions about the remote monitoring, if that's helpful, not necessarily on some of all the detail that you've just asked for, Elena. We have got that and certainly can share that with you in terms of a business case that's going forward. But with regards to remote monitoring, there's work going on across the group and also across the system, looking at how we can do the virtual wards, how we can extend the remote monitoring. So that's work we're currently doing with colleagues across the system through some of one of the ICANN pillars, actually. But so yes, we have got some of that detail. I'm happy to share that further. We've got a detailed business case if that's appropriate.
Okay, David, your hand's still up. I take it that's an old hand, is it?
Yeah. Apologies. Yeah.
Yeah, okay. Heidi.
Yeah, so just to echo what Karen said really in response to David and Elena, there is inevitably a national push on what we can do to provide care in the right place, and at times the virtual ward is obviously a very current initiative, and we've been really successful in what we've done so far. We did double our capacity during winter, and we're continuing to look, as Karen's referred to, at the benefits of that and realising the benefits of that at the moment in terms of the very questions you're asking, Elena. So the teams are working on that, what we can learn from what we've already done, what other ways can we use remote monitoring. We use it in maternity, we use it across the trust, but where else can we use it more effectively? Then there's also the virtual wards as well, which is slightly different, but that's managing patients virtually for things that currently they can be admitted for. So there's a number of different initiatives in terms of managing patients virtually, whether it's through remote monitoring that we're really working through ICANN with the system, but also internally as a hospital, what can we do different? Because some of it's about confidence from clinicians that there is somewhere for those patients to be followed up. So we're really working with lots of specialties to look at what can we do differently. So they're very current in light of the discharge programme, which Palmer will cover later. What else can we do internally and what can we do with the system? So as Karen said, we can link with you on the current benefits realisation, what we've already done and what that means for what we're doing next.
Okay, any other hands? No. Palmer, you want to finish it up?
Yeah, so and I think it's the virtual ward piece. I'm just trying to find at the moment what the actual target was. It's not on the top of my head, but I think it's also important.
For the county. I think it's 800 for the county.
There we go, thank you. And I think it's also important with the virtual wards, not just and the way we think about it, there's also virtual admin wards that we've been talking about with some of our clinicians, so they can discharge patients and just keep an eye on them, so we can then actually chase up results so we don't lose patients. And we're doing a lot of work in terms of trying to share some of our ward-based work in a virtual environment on our iBox with the system out to NHFT and across the council, so we can support discharges. And actually we can then visibly move flow around the system, not just to virtual wards, but also to the nursing homes in other areas.
Okay, thank you. Any other comment on that at all? It was a good bit of video, and there's a theme to today, so I'll come back to that in a minute. Okay, minutes of the meeting on the 27th of January. Are you happy to refer record? Yeah, good, thank you. Chair's report. Well, I've already mentioned the call last Friday, which was a mandatory national call with the National Director of Operations for the NHS, Chief Operating Officer, and various other luminaries, which was focused to some extent on ambulance handovers, and we can talk about that in the IGR section. But clearly, that an ambulance handover problem is not focused on just the emergency department, but rather focused on flow throughout the hospital. So you'll see there's a theme through today with Palmer and others talking about the flow issues within the hospital. But I mean, linking that to the news today, where we've got the Nhs Satisfaction Survey with pretty perilous performance in a number of areas. Again, we're not in a particularly bad place here. And in fact, in some areas, we're in a very good place around our elective waiting times and so on. But clearly, NHS satisfaction by the public is at a remarkably low level, particularly focused on GP access, it would appear, but also waiting list and cancer performance. And of course, our waiting list performance is a function of our discharge performance. You can't bring a patient in unless you can get a patient out. So again, we'll be focusing on that throughout the day. And I think from our staff point of view, as we start to talk about some of the staff issues today, because the Nhs Staff Survey is published today as well, and it recognises that not only are our patients in the public not very happy with the NHS, I think we might recognise that our staff aren't entirely happy with the pressure and the workload that they've been under. So there's a real requirement to make sure that the winter of 22-23 is not as bad as the winter of 21-22. And of course, our new integrated care board starts in shadow form on the 1st of April, which is just a couple of days away. And the board meeting that they will be holding in April will be focusing to a very large extent on ICANN, Integrated Care Across Northamptonshire, which is the acronym for the massive planning exercise to make sure people don't come into hospital unnecessarily, don't stay in hospital unnecessarily, and end up in the right place. So, as I say, there is a theme throughout the day about that kind of topic. So that's all I wanted to say about that. Over to you, Simon.
Thanks, Alan. A few points from me in support of what you've said. So we're at the turn of the year, the first end of the financial year, first planning round we've run in 2 years, a very different type of planning round, because we're moving away from a planning round based on institutions to based on system first. But 3 quick themes to pick up in my comments today. So the first is, we start, as Alan, you've said, a kind of a return to post-pandemic activity in the NHS in a pretty strong position on a number of respects. In particular, our elective waiting performance, our cancer performance, is among the best in the region, in fact, the best in the region. And that gives us a strong basis in which to start our conversations with our system partners going forward. In our first planning submission, we were the only system in the Midlands to be clear that we would have no 104, no 78 or no 52-week waits in the year ahead. We will deliver the cancer standards, and we will start to make the changes in outpatient transformation that are required of us across our system. And of course, we have that inheritance, we have that based on the enormous hard work of staff who've helped deliver that position. And I just wanted to take a moment, particularly in the context, as you say, Alan, of the staff survey results being published today, to thank people for giving us that place to be. We are in this system first world. Our elective performance, our elective activity, our planned care activity is associated not only with making sure patients don't experience any waits any longer than they need to, but with significant financial incentives. And the number one ask our system partners have made of us is we achieve those levels of planned care activity to maximise the income that can come to the system. It is significant amounts of money, and we will talk about that both a little bit in the public section, but more in the private section of the board. I've described it to you, Alan, and I would describe it to board colleagues as our licence to operate. It demonstrates that we are credible system partners. We have a real appetite to deliver. And indeed, given the position that we find ourselves in at the end of March with the waiting list that we have, we are in a strong place to make that aspiration a reality. I'd like also to pay tribute here to the work of Karen and the planning team and Palmer and the operational teams for all the work that they've done to get us into that place of being able to start with such a strong conversation. Secondly, as you've already alluded to, today's theme is really about discharge. The number one thing that will enable us to deliver all that I've just described, or indeed will hamper our aspirations in this regard, is discharge. It is often overlooked in some of the performance metrics. We tend to talk about 4-hour wait, ambulance handover times, 52-week wait, but the real enabler of all of those things is discharge. And I really hope today that we can have a rich and full conversation on the totality of discharge. And Palmer, I think, has done an excellent piece of analysis that gets us into that conversation. I would say only in my comments that it's important to say that I think we should come back to this time and again throughout the year, because if we get this right, we're going to have a great year. If we don't get it right, it follows fairly axiomatically that the year will be really quite tough. So a real strong opening, I think, to the debate today. And you're quite right, Alan. The challenge falls into 2 parts. Part 1 is what can we do in the hospital to further improve our performance? And I do wonder, listening to our patient story this morning, as to whether we should, as a board, take up cudgels. I've worked in the NHS now just over 25 years. As long as I've been in the NHS, and I'm looking around to try and work out who's served longer, I know some of you have, TTOs have been an issue, and I wonder whether we should make that a bit of a cause célèbre for us to really try and be the first hospital that's cracked it. You were talking about it, Elena, from your personal experience. I think all of us who have known or have been in hospital or have watched people go through hospital would say TTOs, you may have solved it, Andre and Leicester, but TTOs is probably the one big thing that I think is a function of discharge. And I wonder whether we should set ourselves that challenge. I will leave that question hanging to see whether we have appetite to really get behind sorting out discharge. I'm sure there's an award or two to be won there. Thirdly, on people, we meet in the context, as you said, Alan, of a very sharply declining satisfaction survey with the NHS. We are one system, so we're going to have to work out how we get behind some of the issues that there are in primary care, even though from our point of view, access remains strong to our services. But we know that our staff tell us, our patients tell us that access to primary care in Northamptonshire is sometimes quite variable, ranging from the extremely good to the extremely challenged and everything in between. We also know that our staff survey is published today, and today really marks the opening of a conversation that we will bring to our board development session, then back to boards in May, about how do we respond to staff survey and some of the challenges that are associated with it. It will not have escaped people's notice that today also was signalled the fact that car parking charges for staff or free car parking ends tomorrow. We are talking about that with our system partners. At the moment, we intend to make no changes to current car parking charges, because I believe it's one of those things that we really do need to do to try and demonstrate our support for staff when they are already facing a number of other pressures on pension changes, on cost of living increases, and indeed on the health and social care levy. We will need to take that step finally, collectively as a system, but it is one that I think shows that we are trying to do what we can to make a difference to our staff. And I hope that we can all get behind trying to make that a reality. Again, I believe it is something we should step over the line as a system, not just as individual organisations. We should say that we stand for NHS staff in Northamptonshire not having to pay to come to work and park. Finally, today, we've already alluded to it, the ICB goes into shadow form from April through to June. Richard published the clarification in the chat, but just to make sure that people have that correction. We take up our seats around that table. It will be a busy period of time because we have got the planning submission to consider at our first meeting. We will be considering ICANN at our first meeting, and a huge range of in-trade tasks comes to us. The key test of how we work is not just the tasks we face, but also how we respond as a system to them. We've got to go into this not saying, I blame you, but how do we solve this together? And I will finish my comments there. Thank you very much.
Thank you. I think we'll go straight on to Heidi. Heidi?
Thanks, Chair. So following on from Simon, I'd like to start by thanking Karen, Bowler and Palmer and teams for their really hard work in the planning round. That has been fairly relentless alongside the pressures that we're facing along our urgent care pathway and maintaining elective and cancer activity. It's just to reiterate that. What I'd start with is the current position that we find ourselves in the hospital is still incredibly pressured. In fact, we've been on an escalation call before board this morning as an executive team. Now, this is due to some of the facts we've already discussed in terms of discharge, high number of attendances in our ED, and rising COVID numbers again within the hospital and obviously across the community. So the teams are working incredibly hard, but they've been working incredibly hard under pressure for a long period of time. So staff wellbeing, really focusing on how staff are feeling has to be a continued focus for us to making sure we're doing everything we can within the hospital and across the system. So on that note, just want to really thank everybody for their continued hard work. We are, seeing the impact of that on some of our teams at the moment. The opportunity that brings is, as Simon and Palmer have referred to, and yourself, Alan, is we do have an opportunity being part of a national discharge programme to really, truly tackle the challenge we have around discharges. Some of the long-standing discharge challenges we've had in Northampton have been here for a long time, and we're really using this opportunity to really unpick from the front door to discharge internally what we can do better. So we absolutely take your challenge, Simon, on TTOs, but it needs to be much more than that. This is a real opportunity for us to really unpick every part of the pathway. We're really open to learning. We've got a number of colleagues, system colleagues and external colleagues supporting us in really understanding the challenge and making sure we do this really well. So teams are on board with that, and we're really open to learning as from Katrina's experience. It's important we learn, but it's important we do it properly. It's important we really unpick all of the issues we can do ourselves as well as the challenges in the system. The staff survey, as Simon alluded to, is being published today. I think it's important to say this isn't where we'd want it to be. Staff satisfaction is absolutely not where we would want it to be within the hospital, and it's really important for me personally to say I'm hugely committed to changing the experience of our teams and creating an environment where NGH is the best it can be to work for our teams and obviously to receive care, because there's a direct correlation. Staff survey was obviously done a number of months ago, so that's one insight which is published today, but there are a number of other insights we have available to us, the pulse survey, and obviously engaging with teams on a continuous basis, which just allows us to constantly think about what our response is. But the important point to note here at board today is that we're absolutely committed to a journey of improvement. Recognise that some of the things in the staff survey are an absolute reflection of how teams are feeling, and it's an absolute commitment for us to really unpick. We're creating safe spaces, how we can ensure teams feel part of the solution, because some of this is about how people feel valued, how they're valued as a whole person, and that they can feel that they can make a difference in their role. So it's important to acknowledge that. Having said that, there is a lot of really good stuff happening here. So I think it's also really important to make sure we balance the absolute relentless pressure that teams are under and the decrease in patient satisfaction and staff satisfaction with the really positive things that are happening here. Now, I've noted them in my report, but just, and Simon has already referred to our elective position. Our cancer performance is incredibly positive in terms of a comparator to other organisations. That doesn't mean we're becoming complacent. It means that we will continue to try and continuously improve where we are on delivering the best cancer care we can, particularly in light of us being a cancer centre of excellence. There's some bits within my report that we can pull out in terms of the team working incredibly hard on pulling back our breast screening position and us being part of a Grail cancer study. Equally, as we discussed at the last board, we were really delighted that we got our first robot as a group of hospitals across UHN, and we're delighted to say that it's been implemented safely and a number of patients have been operated on with the robot and with successful outcomes. So, and we can't go without acknowledging the absolute dedication of the team, making sure that that was implemented safely. The breast screening programme implementing the robot are really good examples of the teamwork we have here at NGH that is really humbling to see on a regular basis. And there's obviously lots of other teams too. We've also been successful in securing just over 20 million for the government decarbonisation scheme, which takes us a long way to our net zero ambition. So that's really positive. And we will soon be opening our new ITU, which is, a huge achievement for the organisation and our teams in terms of delivering ITU care in a much more patient-friendly and staff-friendly environment. So that's going to be finalised soon. And the one final thing I'd pull out is it was a year on Tuesday, I think it was, last week, that our international nurses had come to NGH as part of a system-wide collaborative with KGH and NHFT. And we went around to celebrate not only welcoming international nurses themselves, but to celebrate teams who have really welcomed these international nurses into their teams and really celebrated the diversity of thinking, the diversity of experience that international nurses have brought to those teams. So that was a real pleasure to be part of, but something to really take a moment to think about how we're improving our staffing position, not only in terms of numbers, but in, like I say, diversity of thinking and diversity of approach. So I'll leave it there, Alan, unless anyone's got any questions.
Okay, thank you. Anybody want to pick up anything that any of the three of us have said today? Some of them will be coming back to you, of course. David and then Elena.
Sorry, just trying to find the mute button. Yeah, thank you very much. It's actually a question for you, Heidi, and I think anyone who uses Northampton General Hospital as a patient understands the pressure which staff are under. And I did visit a couple of wards last week with Karen actually, and we did see the reality of what the situation is like. Staff were under real pressure. It's good to know we have someone with your empathetic approach to leadership and management, however, leading the charge, Heidi, may I say that. I also had the opportunity to visit the critical care unit, which is absolutely great. And I'm sure it is a cutting edge facility of that type. And I hope it will open very, very soon, because it will be a tremendous benefit to our patients. My question is about estates, however. The accommodation block has been talked about a lot over the past couple of years. We don't really seem to advance much on that particular project, and it's fairly important for both our nurses, who we hope to recruit and retain, and for our junior doctors. So first of all, I wondered, what is the progress on actually getting some form of accommodation block or new accommodation for our staff sorted out? And the other one was some comments which were made to me by some neighbours actually, who recently had to attend A&E. Is there any possibility of us doing anything infrastructurally different with A&E? It really isn't a fit for purpose unit. If you go around it, it's not somewhere which leads itself to the process that we want it to be. Is there any opportunity for us trying to do something there? I'm not saying build an entire new unit, but maybe I am saying that. So a couple of points there.
Okay, Elena.
Thank you to Alan, Simon and Heidi, because all of you mentioned the staff survey and how important it is to reduce pressure on our staff. And thinking of this, I was again looking at the front door pressures. And actually, it's great that only 16% of people who are coming to our A&E really needs to be hospitalized. It means that 84% of people are sent back home. So my question, what analysis can we do? Is our A&E is really right place to examine and treat these 84% of people? 84% of people, it's almost 300 people a day. Are there better places for them to be treated and therefore reduce unnecessary pressure on our staff? Thank you.
Elena. Andre.
Thank you, Chair. I was a bit slow in raising my hand earlier on the previous session, so I'm catching up a little bit. Just a quick question on Palmer's comment, and then I would ask about the TTO bit that Simon has flagged. So Palmer mentioned about the virtual clinic, I presume. He was mentioning about clinicians having time to review results and then correspond with GPs and other clinical colleagues. Is there a special tariff for that? Is it funded activity that there's a very clear money trail for that? Because obviously clinicians' job plans are quite often overfilled already anyway. So to do additional activity, you need to find the time and space to do that. So that was just a quick question. TTO, since Simon flagged it up, it's a mystery to me because obviously I've not been involved in management in my institutions. I often wonder why there was a block. I suppose we don't want to make errors in prescribing drugs and dispensing them for patients going home. Sometimes you need to probably dial in a lot of common sense, which is probably lacking in some of the areas. Is there any deep dive on the process where the pinch points are? At Leicester, obviously, we have discharge lounges, which to me is a bit like kicking the can down the road a little bit. You discharge the patients from the ward, but they wait in the discharge lounge, which okay, works. Okay, if you can sort of put some resources there. But I wonder if technology can help us if the pinch points are demonstrated to be that physical disconnect there. Just a few points there to raise. Thank you.
Okay, thank you. Right, Stuart, I take it you're going to come back on the fabric question.
Yeah, I think I'll try and help out Heidi on that question. So accommodation first, David. Yes, we recognise we do have challenges with old building stock and our accommodation. This year we have invested actually and upgraded a number of the rooms. So a lot of our on-call rooms, a lot of our doctors' rooms have been upgraded. We've worked with the university and they've helped us out with additional off-site accommodation as well, which is better than ours. Not ideal because it's not on-site, and we continue to work with them. The opportunity to fund a new build, so we do have plans for a new build. And I know you've lived through this as well with the opportunities available to seek funding that with new financial regulations has been really difficult. But it is back on our agenda. We are confident that there is a structure that will pass our auditors' scrutiny, and we can do this right to find additional funding. So it is high on our agenda to build a new accommodation block, but it is extremely difficult to find the funding to do that, but it is high on our agenda. A&E is another difficult one to get into. So we've been fortunate this year. We completed the £3 million paediatric build. So that's been a fantastic addition to ED. And what we've done in ED over the last few years, we've invested quite a lot in there. So we've got new frailty units, SDECs, COAs. It is difficult to get in there. The new William Kerr building, well, handed over in 2018 with the assessment wards, has also helped us with that. It's a difficult area to get in. We can't close it, clearly, and I would love to build a new one for you. But at the moment, the funding isn't there for that. So we continue to work with the team down there and invest and change and support them.
Thank you. Other responses to Elena's point and maybe Andre's point as well. Palmer or Heidi?
Yeah, thanks, Alan. I'll try and bring a few points together. So on the accommodation point, as Stuart said, there's been a number of movements, but there's still a lot more to do. Charity are also helping us with some of the accommodation. In terms of ED, David, I'd be delighted if we could build a new ED. But in reality, there are things we can do. So some of the work we're doing, working with the National Discharge team, really unpicking the pathway. We're getting a number of external peer colleagues. In fact, we've got ESIST in today looking at some of the pathway at the front door, and we're really unpicking what else we can do. So it's tied to some of Andre's point in terms of really process mapping what the pinch points are and what we need to do. We're also having some very constructive and collaborative conversations to make sure that everybody has a voice in this. So had some really good conversations in the last couple of weeks with consultants around what is really blocking them from their perspective. Some quite small things, but will have a big impact. One of the biggest things at the front door, which we're currently talking to the system and national and regional colleagues about, both Simon and myself, is about we don't have an urgent treatment centre on the west of the county. So we don't have an urgent treatment centre here at all. And so we're managing a lot of the attendances that could go through an urgent treatment centre in our ED at the moment. So that is something that could, from an estates perspective, make quite a difference. So our operational and estates teams are working on what those options could look like on a site, because largely when they're on an acute site, they're deemed to be more effective. So that's a very current conversation, and we're hoping to get that. Karen's working on a business case with operational colleagues to move that forward this side of the summer so that it is able to have an impact ahead of winter. So that's something that can make a really tangible difference. In terms of attendances, Elena, absolutely agree with you. There's a number of factors in that, in terms of sharing risk across the system, having transparency around access to care. Some of this we need to do at place-based level and are starting to really drill down to a locality level to really understand what attendances are we having that are unnecessary. Are they coming from specific places? So working with partner organisations on really understanding that a lot more so that we can proactively respond to that. Some of it is about patient expectation as well, in terms of A&E is, there's been some national research that has shown, because of their continuous ability to access an ED department, particularly for people who don't get sick pay, for example, there's a number of drivers for why people come to an emergency department over and above other services that they could access. So some of this is about us building public confidence in all of the services we have across the system. So there's lots to that question, but yes, there absolutely needs to be more work on admission avoidance, which ICANN is picking up, more around how we make sure we don't admit patients that we don't need to admit, and we confidently either put them in a virtual ward, which we've already referred to, or we work with partners to prevent them coming in the first place. That includes working with the ambulance service. So the discharge work, as which Palmer will go into later, will be capturing a lot of that, because whilst it's a discharge programme, a lot of the work and the national discharge programme, as in Simon's report, has a number of pillars, and some of those pillars are about what provision is in the community to prevent admission and manage successful discharges, essentially, so patients aren't deconditioning in the hospital. So very happy to go into more detail as that work progresses, but we really do need to unpick this across the whole pathway and work with partners to hold each other to account on where patients are best treated.
Okay, thank you very much. Final two comments, Becky and Simon. If I could just maybe gently remind people it's a public board meeting, and could we just translate some of the acronyms when we use them? SDEC, same day emergency care, NSIS, and so on and so forth. Becky.
I just wanted to come in on Heidi's point around the work with the system in the ICANN programme. One of the things that the programme has just completed this week, actually I had a demo earlier on this week, is around exactly that, around the ED dashboard and the data, you know, who is coming in, for what reason, where have they come from, which practices have they come from, what sort of conditions have they come into. So we'll be interrogating that in detail and making sure we're working with partners to put in place some of the interventions that will prevent that. So I'm sure we can come back to a future board when we've done that detailed analysis.
Thank you. And finally, Simon.
Just to support particularly that point about the urgent treatment centre, I think it's critical. The only addition I have to make to it is, if we're going to set it up properly, the decision needs to be made within the next couple of months tops, because otherwise what will happen is funny money will come out in October, November. We run around trying to put up a porter cabin or do something, and it doesn't really work. So if we want to make a success of diverting attendances to an urgent treatment centre, we need to push our system colleagues in a collegiate enough way to make the decision sooner rather than later. Otherwise, we will not have enough run-in time to get it up and running by next winter.
Okay, thank you very much. Good run through on all of that stuff. Item 5, and congratulations on the 20 million decarbonisation money and on the robot. Pretty impressive stuff. Integrated governance report, which has not been without its troubles. Andy first, and then I shall hand over to Heidi to compare the process through. Andy, I think you're first on this. Where are we with this integrated governance report across the group?
Yeah, thanks, Alan. And you know, I need to start with an apology really to folks that we the progress, as Alan said, made on this isn't as where we'd like it to be. It's certainly been more challenging than we naively thought it would be. And so what you have here is a pack of the 26 metrics that are have got validity and able to withstand the scrutiny through the committees. Obviously through the committee cycle, those metrics have been augmented by other reports. So that's not the only numbers that committees have been able to discuss along the way. But what you'll see in the pack is an update of where the metrics are and the progression to get towards all of them being in place. Work is planned to continue to chip away at those metrics and get towards all 90 of them being in the IGR. But my view is that will take about 3 months to do. And so each time you'll get an increased number of those, and we continue to work through that. So happy to take some questions on that direction of the travel. And I know there's been some feedback through the committees this time around as well.
Yeah, thank you for that. I mean, I think you're right that when you first looked at the scale of this work, it was underestimated, and we created some space to tackle it, and I think we underestimated it again. So here we are. I think the great trick now, everybody, is not to underestimate it a third time, but to make sure that we lay out an achievable time frame for a group integrated governance report. Partly for simple reasons like getting committee dates and diaries. Our two big performance committees, Performance of Finance, Quality and Safety, it is not really productive for them to meet as a group until there is a compare and contrast fully functioning IGR. And I think also I am, as you will be, Andy, well aware that some of your staff are working till midnight, and some of them are under a lot of stress, and that's not a sustainable position in even the medium term, let alone the long term. So I would simply say to you, let's think very carefully about what the time frame is for this. In the great scheme of things, it actually doesn't matter if we get this together in June or September. It would be good to get it before that, but it is more important that we get it right and that we do not burn out some staff who are difficult to recruit and retain. And it's important that we set ourselves realistic targets for this. So I think that's what you said in this. And I would just say to you, over the next couple of weeks, let's try and harden up on what is an achievable set of timeframes for this. Anybody else want to comment at all on Andy's contribution? And you know, sorry, just to say, I don't think it's either surprising or anything to do with blame on this. This was a remarkably difficult thing to undertake. And whenever you look at trying to line up definitions and data sources and metrics and so on between two hospitals, you simply realize very quickly that although all hospitals do pretty much the same thing, they all manage to do it differently and count it differently. So, you know, these are long, hard roads you're traveling here, Andy. So let's not Let's not think there's anything going wrong here. We just collectively underestimated the problem. Elena.
Thank you, Alan, and thank you, Angie, and your team for the work which was delivered so far. I'm really enjoying what Power BI allows us to do, and it's very interactive, very intuitive, great job. I have a couple of questions for you. The first one is probably very rhetorical. It's my second year with NHS, and I understand that it's very data-rich organization, but I still cannot come in terms why in the end of March we're looking at January data. Are there any opportunities for NHS to become more agile and really work with more recent data than 2 months ago? That's the rhetorical part of the question. And another question, do we have sufficient data to be able to build a forecast to show the trends when we look at Power BI? So it will allow us as NEDs to ask forward thinking questions rather than continuously drill into what was 2 months ago. Thank you.
Okay, Simon.
So thanks for your words, Alan. I just want to say we all need to stand with Andy on this. This is an incredibly complicated and difficult task. And the only thing I'd add to your comments is in the same time as we're trying to do this, the NHS has increased its ask of trusts by 20 to 25%. It has got very information hungry during COVID and shows no sign of stopping that, as we will pick up when we talk about the planning round. But we all stand with you, Andy, and I think you need to feel free to call on any of us, either in non-executive world or in exec world, for support to get this done. On your point about forecasting, Elena, I think that's a really good one. So in actual fact, just to celebrate something that is working at the moment, actually Andy's team publish a COVID forecast. So we are now able to generate insights. It's the first of many, I hope, on what's going to happen around COVID, which is quite a salutary story, and because it's going to show that COVID activity is going to go back up again. And I would suggest, if non-execs are interested, if you don't have it, we're very happy to share it, because it does show the power of insight. The other thing I would notice, which I think, linking back to the discussion, which I'm really keen to pursue, it may have passed by, but just to call out that 100 trusts this week got access to software to predict urgent and emergency care demand. I don't know if people saw that story. I think for us, and particularly for NGH, we now need to start looking at that sort of demand, because the compression that we're getting in the ED is predictable to a certain extent. It's complex modelling, but it is predictable. And I want to try and investigate that with Andy to see whether we can get that software in, because by planning our demand or planning our capacity against anticipated demand, we can make staff's working lives better, as well as provide a better service.
Okay, I know it sounds counterintuitive to think you can predict emergency department attendance, but actually you can, and it's remarkably repetitive. Andy, do you want to come back on any of that, or are you all right?
Yeah, so just coming back on the data and why this month we're looking at January data, you'll see is actually a mix of those things. So there's some elements where there's a validation period. While we're still on using a lot of paper, some of the episodes that happen then need to be coded correctly, and so there's a period of adjustment where that data is coded to the right different specialty and episode and morbidity. And then also that then goes around a sort of a cycle to validate it, particularly the cancer data, and that is traditionally there. So I can probably sort of give you a bit more information on the timeline for how that happens. But what I will say is, as we become increasingly more electronic in our storage, the possibility to speed up that coding process and the validation will come in. We're kind of victims a bit at the minute of our storage collection methods.
Okay, thank you for that, everybody. And it's mentioned in a number of the committee reports you will see as well. Anyway, Heidi, over to you to compare this part of the show, please.
Thanks, Alan. So just to follow up on, I'm not going to draw any out specifics because Simon and I have covered some of them in our intro reports, and I know Palmer's covering a lot of it. But one thing I did want to assure the board off the back of the conversation we've just had is, whilst we may have collectively set the starting point inaccurately, there's been some really good learning from that, some really collective and collaborative discussions around how we can learn from that and move forward. And I'd just like to support, as Simon did, Andy's commitment to moving it forward. But it is a team effort. So we've had some really good discussions about what this means going forwards, and it does allow our teams within the divisions and directorates to really think about what Power BI means for them, and to socialise it and allow them to think about, exactly as we just discussed, what proactive indicators allow us to know what's happening in their areas. There is a kind of concurrent journey which we're on, and we are supporting Andy in making sure we're setting the expectation right and learning from that, as any organisation should. So as we go into the committees, if it's all right, I'm going to leave quality committee until later because Matt isn't here. So I'm going to go straight into finance and performance and hand to Rachel.
Thanks, Heidi. So a number of these agenda items are actually covered on today's agenda. So I'm going to talk about the discussions we had around them. The first one was group performance. The first thing I think is that we welcomed the first joint F&P report, and thanks to Palmer and Fay for pulling that together. Sorry, too many P's in that sentence. Because actually, I know the IGR isn't where it needs to be. I know the data isn't where it needs to be, but we have been asking for this for some months. And I think the fact that they actually pulled together a report where we were, for the first time, able to compare the hospitals side by side was really welcomed. Improvements, obviously, are dependent on strengthening the data, the management information, etc. But I think the report as a whole was excellent. Also, instead of diving straight into the detail, what we did do was pulled out, or Palmer did, was the key metrics that we needed to discuss around waiting times, around elective, cancer, ambulance handovers. So the discussion was able to be much more focused. So in summary on performance, it was a strong performance, which was good to see. I think actually the conversation we had was around the requirement to embed the transformational change. At the risk of repeating myself, as I have told this story to several people here, I attend Cancer Board, and although the cancer performance is excellent comparatively, and the team have absolutely to be applauded on that, I see also the toll it's taking on the team to meet those targets, and the transformation that Becky, your team is doing, Palmer, your team is involved in, is absolutely key to being able to sustain meeting these targets. An example is the planning of consultants, the resources across the board in terms of in cancer delivery. One of the departments said, well, we've got our only 2 consultants retiring this year. So my question is, actually, we don't just have to embed the transformational change with the work on the pathways, but also the demand and resource planning is key here. If you've got your key resources retiring, we should really be looking at this, a year ago. It can't be beyond the wit of all of us to be able to join these things up. Then we moved on to discharge, and I'm not going to steal Palmer's thunder, but obviously it's a key enabler to improving performance. It's adversely impacting our operational performance. We focused really the discussion on the ongoing activity to unpick every part, to look at a longer term solution rather than the quick fixes, which would require a huge amount of effort to sustain. Also, we talked about the need to work collaboratively across the group, and that will be requiring honest conversations with the system around risk. In terms of financial performance, again, this is covered by John shortly. So we were pleased to note a year-to-date surplus of 1.4 million, which was better than planned. However, all eyes are on landing the year-end position where we are forecasting to get to break even, and we have the plan to achieve this. If all assumptions land, that is, we'll get to break even, and I know John will comment on that shortly. One of the concerns we have had over the last few months was our capital expenditure, or rather our ability to spend it. Good to hear that all but 900,000 has been committed, and the plan is that this should reduce to around 100 to 200,000 by year end. And the team do deserve a pat on the back for achieving this. It's been no mean feat. In terms of estates, planning and contract was next. We discussed at length this, mainly around the conflicting priorities over performance and finance. And again, we're going to go into this shortly. We were very clear that we supported the priority to submit a realistic plan. And the key question is how to get ourselves into the best possible position to have those conversations around the money versus performance. Obviously, we are in a very good position in terms of performance, but that does come at a price. Again, just to bring transformation back here, the discussion led us to conclude there is a need to try to accelerate transformation, better data, better MI, and the sooner we embed it, the better. And finally, estates. We noted the three reports around the PAM, Premises Assurance Module, Self-Assessment Dashboard, and the Corporate Risk Register. We discussed the decarbonisation scheme and congratulated Stuart on achieving that. Basically 20.6 million, and I gather it's around replacing a boiler from 1974. And I think some of you on this call probably weren't even born then, which actually depresses me a little bit. And to de-steam the site, but I will let Stuart comment on that if needed. And also congratulations to Stuart and his team on achieving their sterile services reaccreditation audit. I'm sure that's no mean feat either, and well done, Stuart, to you and your team. Thank you, Heidi.
Thanks, Rachel. John, can I bring you in just to pull out any salient points, conscious of time?
Yeah, of course, Heidi. Thank you. So Rachel's kind of given you the full highlight. I guess probably the only two important things to pick up for the board are the detailed plan that I took through that Rachel referred to. Clearly, those assumptions need to land. There are a couple of specific items in there relating to accruals and provisions, in particular the accrual that we make at year end for annual leave or annual leave not taken, and a particular provision relating to estates compliance, which we'll take through the audit committee and have already signalled to the audit committee as part of our year end work plan. So just to kind of be mindful of that. I have also been in contact with, and this is, I think, a kind of big thumbs up for system working, with our CCG finance colleagues to ensure that we are able to move money around based on our forecast I&E position, to ensure that each provider is able to land in a break-even position. And I've agreed that will mean further funding will move to NGH before year end. a number of circa 1.6, 1.7 million to enable us to deliver the forecast and have that revenue and cash support to make that happen. The final thing to pick up relating to Capex, so Rachel's given a summary of the briefing that I gave, just to say there is a lot of work going on now over the past few days, and will continue up until Thursday, around securing in terms of taking delivery of items that have been promised to us by suppliers, but also signing off numerous vesting certificates. The vesting is essentially where we as an organisation agree to take on ownership and the responsibilities of that ownership for goods and services before we physically take delivery of them. It's quite common to do this at year end, but I need to flag to the board that we are going through a number of processes with a number of suppliers to land those numbers in those areas. The plan is in place, as Rachel has said, expecting us to land within a couple £100,000 of our overall spend envelope of 27.5 million. That includes the spend that we had committed around TIF, which for digital TIF, that's the transformation funding that we received some way through the year of some circa £3 million. So that's it for me, Heidi.
Thanks, John. Can I just extend Rachel's thanks to Stuart, to Paul Sheed and team, obviously, for the site-based leadership of the decarbonisation grant, and also John, to yourself and Bola and team, because of all of the hard work for getting these schemes through and year end. So thank you. Moving on to People Committee, if I can bring Denise in first, please.
Okay. Thanks, Heidi. Yes, as Rachel said, actually, there's a number of things that we discussed that are on the agenda, so I'm not going to go into detail or steal anybody's thunder. The first one on our agenda was the communications strategy, which is on the agenda here later, so I'll just move on from that. In terms of the people plan, again, that's on the agenda, but I just wanted to put a little bit of context into that, in that there are several items on the people plan, and indeed in the people performance now, where we have requested specific timelines and dates for pieces of work to be completed. So mandatory training, which I saw came up in more than our committee, which we all acknowledge is something that does need a focus on it. It's not something that's going to be rectified overnight because of the scale of what needs doing, but we do need a proper plan in terms of how we're going to catch up and how we're going to move forward. So Mark and his team are working on that. Likewise, the collaborative bank model, the issues there that need to be resolved in terms of parity of pay. We're asking for some specific timelines and dates on that, and the new appraisal process is the other item, where we've asked for timelines and specific project plan. All of those are things that will help towards unlocking some of the other issues that we've got, particularly around the staff survey results. So an increased focus really on timelines and dates there was made quite obvious, I think, at the committee. In terms of the safe staffing, and this is wrapped up again with the people performance side of things, there were a couple of big areas that we focused on again and talked about. The one is, unfortunately, the increasing absence rates. So the rates since the removal of any of the COVID restrictions, the absence rates are increasing, perhaps slightly sooner than anticipated and maybe faster than anticipated in staffing terms, coupled with obviously increases in patients coming into the hospital. So that is becoming, that was on a downward trend. It's back on an upward trend, and the implications of that are obvious. One of the other aspects that we talked about was around the health and well-being side of things. We had a very interesting presentation on that. I think that the point that was made here is that we need to perhaps as a committee focus more on the output side of things. So there's a lot being done, and a huge amount of thanks that we do say every committee to Mark and his team, who are putting a lot of work into it, and I know a lot, you know, compared to other hospitals. So we've got lots and lots of initiatives there. What we've asked for is a bit more focus on the output, in that some of the initiatives don't reflect how people are feeling. So, you know, we're still getting people feeling burnt out. We're still getting as the staff survey has shown, we're still getting people that are not happy, if you like. So some more work is being done on what we track and how we track and what the outputs of the work are. And then the final big discussion item on the committee, which I'm not going to say anymore because there is a whole agenda item here, but it was around the Ockenden report, and in particular the sort of felt vacancy rate and the impact of that on maternity staffing and care. Thanks, Heidi.
Thanks, Denise, really helpful. Can I bring Mark in now, please?
Of course, thank you, Heidi. Morning, everybody. So there isn't much more for me to say. Everything I had in my list, Denise has absolutely covered off in terms of our conversation on Monday. I think it is important to highlight the conversation that we've had today and the theme around the agenda that's already been stated earlier in the meeting, you know, that our pressure impacts clearly on our people. The pandemic is having a continuous impact on our availability of people to attend work based on contracting the virus, as it still is at the moment. It sounds quite ironic for me to say that at the moment. And clearly that has impacts in terms of how people feel. With less people around, we've got less opportunity to develop them. One of our strengths as an NHS is developing colleagues and supporting them to enhance their career, and that's something we're not able to offer as much as we would like when we're under periods of significant pressure and continuous significant pressure. So I won't say any more than that because we've got another whole agenda item later on.
Thanks, Mark, and thanks again for everything your team are doing, both in the things that have been discussed, but also in from an EDI perspective, which is making quite a big difference. Thank you. So I'll move on to digital now. Normally I bring in Andy first, but it's Andy, David. Does Andy want to come in first?
Yeah, thanks, Alice. So Heidi, sorry. wrong meeting. Yeah, so yeah, good meeting earlier on this month. As normally, we went through the 8 themes in the group digital strategy and tracked progress on those. A mention for the TIF funds, and I'd just like to say thanks to John's team, the procurement and finance team have worked absolutely tremendously to get that amount of procure that much stuff in such a short period of time. I don't know if anyone's ever done it that before, so that was massive thanks to them for that. We also reviewed a cyber resilience paper. There was a request from the national team and looked at on how we were doing against that. I think we're able to give assurance to the committee, and there's a number of priority actions that are following up on that. Noting around the progress on the NGH electronic patient record programme, still working through the national funding challenges there. And there was this disappointment expressed around the progress on that. This area for success or celebration in there is that we disaggregated the electronic medicines prescribing administration system and also the pharmacy stock management system, and those have been procured now and in the process of planning for implementation. So it's not, everything hasn't been stopped up down to this national funding. There's still work ongoing around EPMA and pharmacy, and also expanding the use of Vitals and Connect across our organisations. But and since the meeting, we've had some really positive conversations at a regional level about how we unblock the funding arrangements for the EPR at NGH. So I'm feeling increasingly confident that we'll actually get into that process and get that approval done. And the final thing to mention was around the Northampton shared care record. many colleagues on this call saw a demo of that during this month. There's been some further problems with the GP data this week, which has stopped it going live, but that's been looked at now. And I don't even mention a go live date because we've been here before, but teams are working really hard to try and resolve the issues that were there. But I think that, you know, the motivator for this is to make sure that when it does go live, that the data is really reliable and people can trust it. The worst thing we can do is rush this and end up you know, damaging the reputation right at the start. So David, anything you want to add?
Yeah, no, I think you've basically covered everything, Andy. I would like to emphasize the cybersecurity aspect, which you talked about. I mean, the board will be cited on cybersecurity and should be cited on cybersecurity, especially in these fraught geopolitical times. The other point I would mention is about the Automation Accelerator, and this is the robotic process automation initiative which the trust has and the group has embarked upon. And I think this speaks volumes for Andy's team. You know, it's a tremendous initiative. We are an NHS Centre of Excellence. We're providing services for many trusts. I don't know how many, Andy, 15, 20 trusts around the country?
About 20.
And really puts not only NGH but the group as a whole on the IT map. So great job being done by all involved in that. I think the other thing we talked about was the digital team restructuring. I think this is an incredibly important initiative as well. And this will create a single team against the execution of the digital strategy for the group. I think it's the right direction of travel for the group and for each of the trusts individually. And as I say, will ensure delivery of the digital strategy. The two disappointments Andy has also mentioned. The one is with respect to the pace of implementation of the ERP, the electronic record management system. That's not all our fault, as Andy has said. I mean, the goalposts seem to be continually moving. Sorry, EPR isn't it, electronic patient record. But hopefully, come our meeting in May, we will have some better news on that. And again, the Northamptonshire healthcare record again is something where there have been continuous delays. But as you say, Andy, when it comes out, then yeah, we should embrace it and ensure all our clinicians are embracing it as well, because that really will positively impact our patients.
Thank you, David. And again, just to extend our thanks for all the TIF funding getting through. It's been relentless work, as you said, David, in the amount of work that's happening in that team whilst they're embarking on a restructure. So it's important to acknowledge that. Now I will bring in Rachel again for CPC, and then Simon after Rachel.
Thanks, Heidi. So CPC, this is where we have the opportunity to spend some time and space really going into the detail of some of the group strategies. However, a number of the strategies we did discuss have then made their way to other committees this month, because CPC is held much earlier in the month generally. First one to go through this was the group people plan, and the discussion here was really around whether we have adequate metrics in place to assess progress and some of the upcoming challenges in continuing to make progress on this plan around predominantly investing in management capability and capacity, and the need to offer a rounded staff benefits package. We did discuss what was within our gift and what wasn't, and I think there was a strong support to be able to do everything we can in that area. We also discussed the challenges of recruitment and retention, and making sure that we are focusing our time and effort on the work that will really make a difference. We also, the next item that went through this was planning and the enablers, and here it was really looking at how we are going to embed the group culture and engage the staff, developing our managers again, and ensuring that the group support functions, digital finance, comms, transformation, estates and people, are really as ready as they can be to support the hospitals, and this especially given the planning that's going into next winter is absolutely vital. We also received an update on the clinical collaboration and group clinical ambition. In terms of the next steps, which are primarily around wider engagement, so it's obviously vital that, and I see, Becky, that a number of meetings have gone in this month around that, but it's obviously the comms strategy is absolutely essential here, that we reach out and engage with as many people as we possibly can, or as many stakeholders as we can. And finally, we had an update and discussion around the transformation project in outpatients. And again, the discussion was predominantly around developing robust and rounded metrics and also the benefits realization. Transformation projects inevitably are not cheap, and you have to put the money up front, and it takes a while for the benefits to really feed through to the staff. And it's not until it's fully up and working and those staff are using and any of the outputs of that transformation and are working within embedded change, that actually they fully believe that it's going to happen. So again, I think this does come back to communication. I know we're going to hear from Teresa later, that actually we've got to be able to signpost the change that's coming and ask people to really hold their nerve while we push this through. We've also got to be able to fully believe in this and support Becky and her team while this goes ahead. And that's it from me and CPC. Thank you. Simon?
Thanks. Just to add that theme of the day, perhaps, everybody's done very well to get the programs and the products and the purchasing of them over the line. Andy, John, Becky, I had the privilege of attending both roadshows, and the thing I'd like to say just on that is there is an enormous groundswell of enthusiasm amongst staff for us to embrace this journey. There was a lot of energy in the room about how it would make a difference. Everything from being able to signpost patients' journeys to giving them an app to log in and book their appointments, which I think is really positive. However, on the practicalities, we now need to set a timetable of what we can implement over the year ahead. Implementation, as you've already said, Rachel, is not cost-free. So we need to work out a way of, and I think we should bring that back, both through CPC and to board, for our implementation plan around those outpatient transformation journeys. That work will be ongoing through April to work out what we can deliver, but it will be critical to all that we, again, want to achieve. So that will be my only additional point. Thanks, everybody.
Thanks, Rachel and Simon. I could completely agree with Rachel. This is going to need a real collective narrative and message around the benefits of the transformation and how we make those real to our teams along the journey. So completely support that. It says my bandwidth is low, so I'm hoping everybody can hear me, even though I'm on the same bandwidth as everybody else. So if I can bring in Andre and then Debbie, and hopefully Matt will join as we conclude this. Thanks, Andre.
Thanks, Heidi. Just a very brief report on the quality committee that we had last week. So I think one of the things is, I won't dwell in it too much. We've mentioned about IGR. I think it's a welcome work in progress. Perhaps a couple of comments which may be diametrically opposite. One is, as a bit of a data nerd, when we compare two different graphs, one would probably like the scales to be normalized so that you can compare baseline, with one graph being bottom at 50% and another one at 20%. They both look bad, but one is better than the others. So I think, but on the other opposite comment, whilst we're comparing between the two sites, even the metric may be the same on a performance area, we may be comparing apples and oranges. So I think we need to be cautious about the context with which we compare performance areas and metrics. So I think this is one that we acknowledge at the committee and discussed, and wanted further discussions to take into consideration of that context. And whilst we are looking at still a very substantial volume of papers for the meeting, we noticed that some of the key areas had dropped out of the quality committee, which we thought were important to be flagged and to be brought in future meetings. So one is the serious incidents, deep dive, and basically a concluded report on the serious incidents, rather than just receiving the hot cases as we come by email. And the second thing is the emergent care. I think that piece that it appears in other committees, which perhaps is important for the quality committee to have sight of and also discuss. So I think these are the some of the areas that we've highlighted. In terms of the quality report, David asked a very good question, and I think it actually stimulated very useful discussion for my 4 months here. The first time that we had quite animated and engaging discussion, which was to ask the paper owners what were keeping them awake at night. So I think this is, in a way, what we were trying to squeeze out of the paper owners is not just to give us all the data, but to crystallize in the cover page what are the key things that we want to discuss on the day. So I think that triggered a good 10-15 minutes of very engaging discussion, which actually highlighted the importance of looking after our staff, which we acknowledge. I think the conclusion of the committee on that day is that the staff is still under continued pressure, despite the fact that we seem to be coming out of a pandemic. There's a lot of aftermath of that. Pressure is still high. Unreferred patients from the pandemic are getting increasingly referred left, right, and center. Staff are burnt out. There's ongoing demand on recovery, which we acknowledge that some creative solutions need to be created to try and treat that. I don't think we're going to see that for another few years in terms of coming back to the pre-pandemic levels. We also highlighted, as a probably consequence of that pressure and ongoing pressure, some of the metrics are following in a kind of worrying direction. One is on safeguarding training level, which is at 57%. We are worried that if there is, well, hopefully not, a court case, we won't have much to stand on at that kind of level. And also attendance at certain committees and mandatory training is low. So we acknowledge that the clinical team is under pressure, but I think we need to bring our eyes back on the target there. We are very pleased to receive the annual report from the R&D and very pleased to hear about the developments there. So the posts, the academic posts are being advertised, deadlines drawing close. So we need to see what the pickup is like that there, but we're certainly very pleased with the direction of travel there. Very pleased to hear about the innovation about the drug ruler, which is being trademarked here in Nottingham, not Northampton, and being rolled out, and it's a very exciting story there. So I think I'll probably just stop there and ask for any additional input from colleagues.
Thanks, Andre. I'll bring Debbie in first because Matt's just arrived, so just give him a couple of minutes to gather his thoughts. So I'll bring you in, Debbie, first.
Thank you very much, Heidi, and I concur with everything that Andre said. It was a very interactive meeting, especially when we were asked what keeps me awake at night, and it was definitely about supporting our staff and the pressure that is being placed on the staff at the moment. And Matt and I both agreed about the vulnerabilities and the well-being of those staff. I'd like to just highlight that obviously some of the metrics are not where we'd like them to be, but there's lots of projects looking at those metrics and trying to make sure that our patients do not come to any harm. And but you know, it's all to do with the pressures, I think, that we're all under. So I don't know if Matt's got anything else to add.
Thank you, Debbie. So just a couple of points. So echoing everything that Andre said as chair of the Quality Governance Group, just a couple of minor caveats around safeguarding. So the training that's at 50% was only started 4 months ago, and therefore you wouldn't expect all of medical staff to be at trust level, target level yet. That would take 12 months because it starts at 0. And there has also been we have been marking our own safeguarding training a little harshly in that it's actually due for renewal on a 3 yearly cycle, not annually. And so we've been unduly harsh on ourselves just by way of some assurance, none of which is to detract from the main point that even when under pressure, as Andre quite rightly said, maintenance of basic quality supports such as keeping up to date with training and appraisal is essential. I would echo everything that Debbie has said around pressure of work, and we noted in the data presented to the Quality Governance Committee that there has been an increase in incidents reported on Datix as having moderate or severe harm, which to a certain extent you would expect when you have very high volumes of activity and high rates of staff absence, but we are doing everything that we can to mitigate that. And the second concern, the specific concern that I articulated and feel is that as we are entirely reasonably ramping up elective activity to attend to the waiting times of our patients, that there is a risk if we are not really careful to ensure that we are following safety bundles around interventional procedures, that there will be incidents related to those. I would like to take a moment to end on some really good news that was not presented to Quality Committee because it was not available. The data was not available at that time. But for the first time that I have been on the board at Northampton General Hospital, our mortality as measured by our HSMR is better than expected. It is the best in our peer group, and that has not been achieved through depth of coding of comorbidities and or palliative care, which remains below peer group. So that is something that I think we can, despite the operational pressures, take some pride in. Thank you.
Thanks, Matt, really helpful. And just to give the board some further assurance on the safeguarding, that was escalated to me where we did have some gaps in staffing, and we brought back somebody who'd retired, who was an excellent member of the team. So this has been very managed in a live way to make sure if any risks have been highlighted, they've been mitigated alongside the training. But it's a really valid point, Andre. Simon.
Yeah, I just wanted to follow up on Matt's point about the Shmee rating. I know the committee will have not received it, but we should certainly circulate it to board members. And it came up, didn't it, Heidi, in the recent performance review we had with NGH. It is a long sustained downward trend. According to my SBC guru, i.e. Andy, it is now statistically significant. And I think the question I raised, and I think the committee should consider, is what sequence of interventions have been put in place that have delivered that improvement? Some were suggested, and we had a brief discussion about it, but I think, it's worth really noting that improvement. But I think sometimes we don't stop to say, what was it that delivered that improvement? How do we bottle it and maintain it? So I would just put that as an advisory, perhaps, Andre, to the committee to pick that up, because it's welcome and we should be rightly pleased with it.
Thanks, Simon. And yeah, we did go into it in our performance review, and some of the work the patient safety team under Matt's leadership has been pretty phenomenal, which you can't necessarily say is purely down to that impact, that intervention, but there clearly has been some correlation. So it probably is worth the board being updated on that work in more detail at some point in the future, or at least the Quality Committee. Any other questions from anybody else? No. So I hand back to you, Alan.
Okay, thank you very much. Thank you very much, everybody. Just to say, Audit Committee has not met, but I want to remind the Audit Committee that they have to produce a group cost review and something around group benefits at their next meeting, so it can come to the development sessions in April. Strategic Development Committee had nothing to particular relevance to NGH. And I think on the HSMR, the mortality rates, the standardized mortality rates, it is a classic example of compare and contrast and learn from each other. So if it is a downward trend, which everybody says it is, a sustained one, then obviously there are issues for Kettering to think about as a group, the group quality committee. Okay, thank you very much. We're a little bit behind time after all that. So quickly on National Discharge Programme. This is a programme we've been part of in NGH and as the hospital part of it, but our local authority colleagues and community colleagues are also being involved. Palmer, you're going to take it. Oh, sorry, I'm going to sneeze. I have a terrible head cold. Sorry about that sudden noise. Palmer, you're going to take us through where we are with the discharge programme as part of a theme for the day, really.
Thank you. Bless you, first of all. So I think we're all very well versed in the narrative around discharge. We are facing, well, we've had one of our worst winters. We are facing an even worse one, as it does iterative every year. However, we are facing the kind of sum of all of its parts, and it's sort of lining towards this winter when you think about COVID increasing and the different waves that are coming through, staff sicknesses as a result of the different guidelines that are coming out, IPC guidelines, both with staff and our patients coming through, our elective demand, and our ability to keep our reputational prowess up in terms of cancer and electives and no 52-weekers. And then also just the general demand for non-elective care coming through the door has gone up significantly. So if you play that all in, actually we're facing a difficult summer with the increased number of bank holidays coming up, but then we're really facing a difficult winter ahead, and something has to change. And that's why nationally there was the hospital-only discharge programme. It is called that. However, there are 4 work streams. We are work stream 1, the hospital. The other 3 are the interface, so more across the ICS and how the systems work together. And then specifically, number 3 is looking at community healthcare, and number 4 looking at adult social care. So it's containing all of its parts, and it does include us and KGH as a system. It includes the whole of NHFT, and it does not include kind of Stuart Lancaster and the West Northants team. However, they are being included as part of our visits and everything else. So we are including them by default. We have had 2 visits so far by the team, and the chief exec for Chelsea and Westminster, who's stepping up to do the national programme, Leslie Watts, spent a good 6 hours here on Friday going through things, and we presented a really good collegiate way forward with the different chief operating officers and the DAS for the system coming together and actually presenting, and also then looking at our internal parts, which is what I'm going to go through today. Acknowledging there is a lot around ICANN, there's a lot of pre-hospital stuff being done, a lot of post-hospital stuff being done, and also around, as I've mentioned, the hospital discharge programme, they are looking at everything else. But what I want to do today is just walk everyone through where we're at as a hospital, why we're in this situation, and then we can circle back to a lot of those points that were made at the very start with the patient story around TCOs, virtual wards, and everything else. So hopefully everyone's had a chance to look through the slides. The first kind of 12 slides, set the conditions, talk about the hospital and discharge programme, and present where we are. But what I want to do is just go to slide 13, if you've got it in front of you, and that really just shows you benchmarked where we are as a system. This is model hospital benchmarking, which presents every single hospital across the UK. And it just basically shows us across any given parameter where we are in quartiles. As you can see, KGH are on the right side of it, and we are definitely in the wrong side. The top one shows you the number of people waiting over 6 days. And the bottom right chart shows you the percentage of beds that are used for people waiting over 20 days. Now, the national, when you look at all the literature, it uses 7 days and 21, but obviously you can take from both. Expectation is we should only have 20% of our patients waiting over 7 days. We have 53%. Expectation is we should only have 5% of our patients waiting over 21 days. We have 23%. which has gone down recently, back down towards the kind of 20% and just under as a result of some of the actions we've taken the last week or two. But when this was printed, this is where we were. So we are moving in the right direction, but you can see where as a starter for 10, NGH is in a very different position to KGH. Moving through into the next slide, this is quite busy, but I want to try and walk you through what beds we have and how they're being used in terms of discharge. So the left-hand bar just gives you an idea of, we have 608 beds across the trust, and they are split up across loads of different specialties. I've chunked them up to make it easy to go through. So we have 141 beds for medicine and the NIBEVN unit, which is the acute medicine. Care for the elderly has 108. The medical specialties, so gastro, cardio, renal, stroke, respiratory, have 124 between them. Non-elective surgical work, 142, I'll get my words right. And then that bottom chunk in blue is the surgical, critical care and oncology. And what I'm going to do is I'm just going to move those out of the conversation for now, because that's all stuff that doesn't really interact with ED or cause any major issues. It's more the non-elective side. So everything from non-elective surgical upwards. So we're dealing with round about, 550 beds or just less. That second part just shows you on any given day, on average, how many people are waiting for pathways that are medically fit in our organisation. So this morning I came in and I looked at it and it's roughly about the same as this. So total we'll have 150 people sat in beds that are waiting on different pathways. Now pathway 0 is obviously the majority of our pathways that can just go home with no support. But at the beginning of the day, there are only actually medically fit between 10 to 15 people ready to go. Obviously we then declare them medically fit on the day and a lot more go on that day. And you'll see from graphs to come up what happens to them. Pathway 0 to be confirmed is patients which have become medically optimized, but they are awaiting which pathway they're going to go on. So we've started that part, the discussions with the hub, with the system, doing the transfer as a care form, or what previously would have been known as a PDNA, a patient needs assessment, a very bulky form. And honestly, once they get to a decision on which pathway they're going to go on to, they'll then be allocated to pathways 1, 2, or 3. So either home with a bit of re-enablement, to a kind of a step down facility where they'll have a bit of re-enablement outside of their home, or complex pathways on pathway 3. And I will come down and split those down in terms of where those people are sitting and how long they've been in our organisation shortly. As I've gone through already, 130 odd people on any given day are over 21 days and 330 are over 7 days. So over half our beds are with people over 7 days. Now the right hand side uses the same block of beds, but starts to give you on average over February, this data is from, how many we discharged on a weekday, on a weekend, and then as a result on average throughout February. As you can see, very rarely are they reaching 10% of their turnover. And that's really the magic number when it comes down to it, as we'll find out. So in February, on average, on the weekday, we'll discharge about 50 people. At the weekend, we will dip down to 26. And then on an average day across February, that will give us 43. I'm looking at March so far, as of a week ago when we published this, it's about the same. So moving on to then why this all has the impact. The next slide just gives you an idea, a very, very high level idea. And there are more areas to this, but it's the data I can get my hands on at the moment in terms of the pathways that I could be assured of. Ambulances roughly 90 to 100 a day. Walk-ins about 271, well, it was exactly 271 on average through February. That gave us, 361 people a day coming through ED. On average, 281 of those were home, and you can see the subset of Ps within that. And then we would send approximately 40 people to SDEC. It can go up to 70 and it can go down less depending on the day you're on. And then from, SDEC, same day emergency care. And from there, obviously, we will admit people from there. And there is a good tolerance we should have. As in, if we're not pushing hard enough to send enough people round from A&E into our same day emergency care, we're obviously not getting enough discharge admissions from there. The more we push, the more we'll get admitted. And there is nationally, you're expecting about a 15% return from SDEC into your beds. That means you're taking chances. It doesn't mean you're unsafe because they are going to SDEC as another medical or surgical area. It just means that we're trying to push the boundary and they're trying to see what they can do and pull people out of A&E. So on average, that means we're reaching about 58 people a day being admitted. Now, just going back to that previous slide, 43 being discharged, you can see why we've now got that deficit. I've just put 2 examples in here of where we think there's some opportunity, and I'll circle back to this. But the same day emergency care, we have a business case to hopefully open this until midnight this year. That will save another 2 admissions a day. Criteria to admit. This is where, as part of the hospital only discharge program, the ESIS team have come in, done an audit on everyone who's admitted on any given day from ED, and found that on average, maybe 5 patients could be turned around and sent home instead of admitted. And that's through a mixture of, it's not through people admitting because they want to, it's just more education of what's out there and everything else. So bringing that in, A&E could reduce theirs to 51. That still leaves 8 people as a delta. So moving on, it's important to realize that 15 people, it sounds okay, 15 people a day. That next slide just gives you an idea of where we are in terms of where it means every month. It's 15 people every single day. And because it doesn't act like that, we might get one day where we get enough discharges. The next day might be 20 or 30 short. And it comes back to that weekend being very short and the weekdays being slightly higher. Actually, we take big hits on a Monday because we don't get enough people out on a Saturday and Sunday. And at the moment, we are carrying that hangover from the weekend, and we're trying to discharge, but we are working with yesterday's work in ED at any given time. So ambulance handovers, this is absolutely crucial. But when we're talking about this is the canary in the mine for everything else that's going on. Our A&E here, for those, I'm sure everyone's been around it, we don't have much ability to soak up extra capacity for offloading once we are full. And at the end of the day, if our back door gets full, we can't then move our patients from ED into our beds. If we can't do that, they start to swell in ED. Last night, we had well over 100 people in A&E. Therefore, we can't offload the ambulances. We don't have that space to physically do it. So it's not a lack of grip from the consultants in charge or the sisters in charge. They are all hugely apologetic if any ambulance goes over an hour, and they really don't like doing it because they do have a very good relationship with the EMAS. However, these things are happening as a result of the cause and effect. So slide 18 just shows you an idea of where that cause and effect is coming from. Back in May last year, you can see the stranded and super stranded were down at a kind of a sensible level. When I say sensible, super stranded, it wasn't the national what we'd really want if we were top level. However, it was numbers we could manage. So super stranded was under 100 and stranded was under 300. As you can see, since then, it's then shot up and carried on going that way. It has now stabilized and we're starting to bring it down. But at the same time, back in May, A&E performance started to go down. At the same time last May, all our ambulance weights started to go up. And you can see that when you look further at the data down the bottom of slide 18, that actually it did shoot up right at the very left-hand side. That was just when COVID released and we went to a normal position of under 100. And then we started to kind of boil over to the kind of 130 point. And as just a point to prove, back in May, for all the right reasons, we stopped doing super stranded reviews on patients, because actually what you should do doctrinally is work on your 7-day. So as every patient passes the 7 days, we should be doing that check and challenge as part of our board rounds, and that's how we should be managing it. Unfortunately, we're going through a change process with our discharge coordinators. We dropped the super stranded reviews. We didn't pick up the 7 days, and as a result, you can see it escalating. And then just to prove the point again, KGH have started a couple of weeks ago, and theirs have come down. We've likewise started ours last week after trying to get set up through a couple of issues. And now we're starting to see ours stabilize and start to reverse, but you haven't got the up-to-date data because it was published a bit earlier. So as I said at the beginning, I've gone through, the admissions versus discharges and where those gaps are and where some of the opportunity is. But just to give you an idea of why our beds are so difficult to discharge from. Slide 19 shows you that super stranded and stranded on the left again. That second graph, what it does is it splits it down into pathway. And if you remember that first slide, I talked about the number of people waiting in each pathway. And it's around about 70 people in total across pathways 1, 2, and 3. I'm not including pathway 0 to be confirmed yet. I'm just looking at those that are confirmed on pathways. So the blue bars will give you the average days it took us to get them medically optimized for discharged. So that is our business of turning around patients, getting them through the diagnostics and making a decision and getting them ready. So the far right bar gives you the average across all patients, and then you can split it down pathways 1, 2, and 3. So on average, it took us 10 days to get medically optimized for these patients, which they are more complex. So they will take a bit more time. However, once they're medically optimized, we're then starting the process of getting them onto a pathway. It took us on average 15 days to get from medically optimized, to get all the paperwork done, get them through the hub, and then get them accepted onto a pathway. And that is still an internal process. So that's not something we can go and point the finger and blame solely on our external partners. There is a bit of that there. However, it is definitely something we can control and own and should own. Then the top bar, the grey, on average, they're still here for 9 days, those patients, when we took a snapshot. So if you look at the average, it's 34 days for 70 patients that have been here for over a month. They've been waiting to get in this hospital, of which 9 days is part of their care. The rest of it, the 25 days, is all part of just the process of trying to get them out. Now layer on top the other 50 odd who are pathway 0 to be confirmed, which is still coming up behind this. You start to see why 150 patients waiting best part of over a month is starting to really impact our ability to discharge the number of patients we want. So when you split it down, that blue graph is the bottom blue bit is really about us. It's about urgent emergency care, criteria to meet, and everything else, the diagnostics and our ward processes to get to medically optimized. That amber part is a shared part, but we actually play most of the part in that. It's the hub in terms of where our patient needs assessments goes, which are now the transfer of care forms, which I'll come on to, and the hub interacting with the system. And then that top bar, the grey area, is support from our system. That's getting them out once they're onto a pathway. So the next slide just starts to show you what are we doing internally. And like I said, there is a lot going on around this from ICANN, pre-hospital, post-hospital, that kind of stuff. But this is the stuff which we need to own as NGH as part of our business as usual. So criteria to admit. This was something that we've had the hospital-only discharge program come in and support us with. So ESIST, our emergency care intensive support teams, have come in from outside and done an audit on everyone who was admitted on that day. Whilst they were here, because they had enough time, they also looked at the number of people who were sat in the DTA pile, so the decisions to admit from ED. So not just those in acute medicine, but also those waiting in ED at the time. They found that, now it comes back to that point, about 5 patients on average, and they were slightly more than that, but actually that was due to not enough in the notes that they could find, or there wasn't actually something set up in the system which we need to go through. But they were, on average, 5 people a day who there were places we could have discharged them to from ED, or use their home with the support. So we're taking that part forward, and NHFT are sending in their geriatric consultant to start doing some education with our consultants and junior doctors and ED to give them that warm, fuzzy feeling that when they do discharge, they will go to the right places and they will be looked after. Frailty MDT and ED, and that occurs twice. You've got the frailty MDT in ED and also frailty wards itself. Eleanor ward is our frailty ward here. Unfortunately, that is now one of the COVID wards at the moment. Regardless of whether it's COVID or not, we have bedded that area. We haven't given them the trolley spaces they need to be able to turn people around, and it hasn't worked efficiently like a frailty unit for some time. Just when we got to the point where we were going to give them their trolleys, they unfortunately had an outbreak and they've gone red. We are at the moment trying to support another area to give them trolleys. And the reason this is so important around frailty is that the numbers are slightly sketchy in terms of I'm getting 2 different versions of the truth. But however, you can, over 50% of that 58 people who are admitted are over 65 years old. And there are different numbers above that, but that's the bottom line, is over 50%. So in terms of targeting where we can make a big change, that is definitely one of those areas. And one of the business cases this year, you'll see from some of the financial papers, is for frailty. Is to have a full-on frailty service at ED, which is supported by MDT working, not just the consultants. And also then the actual ward are supporting them as well. Urgent care standards are changing, and that's just something we're looking into to make sure that actually we are moving forward in the right way. And actually that's something that slightly separate, but it's included in this to try and make sure everyone understands. Out of hours, GP and the Springfield unit, so just across the way, are we using it efficiently? What numbers are going there? What are we sending? And where are the opportunities we can send? Which is why some of these dashboards we've got that Newton are bringing online will give us an idea of what's coming in and what are we sending. So if there's more opportunity to send them there. Ambulance handover and takeover, and of course our not admitted performance. So we do have a lot of people who are not admitted. There's 261 on average a day in February. And actually we don't get them out in 4 hours. And so we need to look at the reasons why. Other areas we're looking at is the missed opportunities. So this is a new score of 3+ or under. So what basically this looks at is those who shouldn't really be in, there could be other care for them outside as the natural assumption if their new score is low enough. And this is more looking at the wards. ESIST, again, are going to be coming in with some support to do this audit in the coming weeks. And virtual wards. We only have 11 people, I'm told. I got a text while we're on this call, away on virtual wards at the moment. There is a lot of appetite for virtual wards within the medical teams at the moment. The problem being, though, that we can't give them that warm fuzzy feeling that when they do put them onto a virtual ward or send them home awaiting bloods or anything like that actually, if they're the one on call sending them home, they might not be on tomorrow. So they need it being put into a virtual admin ward or a virtual ward that they can be caught the next day. Same day emergency care is a huge part of what we do here. We're already taking an enormous amount, and I think there is opportunities to do more, both in the surgical and the medical domains. Diagnostics is a real key. So to give you an idea, as an example, we've done some time and motion studies. The areas, so MRI, it takes an average of 2 days to get an inpatient from request to an MRI. And if that 2 days falls after the last board round, it'll be till the following day that person's then reviewed. So you can stick another day on it. And then you've got to make decisions from there and then start the discharge process. There is a lot of time badly utilised in terms of not getting our patients down from the wards, so we don't have an efficient runway of people coming through to move through our scanners and use them efficiently. So a lot of work's already been done with our porters, and they've reacted really well to some of the stuff. And then we've now just concentrated on the wards to make sure they can release those patients with some nursing teams, which of course at the moment is very difficult because of sickness levels and the nursing teams on the wards. IV antibiotics, we can get more people out into the community using this. Discharge coordinators, we're re-rolling to make sure they can focus on pathway 0 and get people out the door. And I think board rounds are one of our real successes here, and you'll hear across the entire trust really, and I use that for KGH as well. And this is really where we want to focus. All this other work wants to come into that board round. We've now allocated senior managers, execs, and our relevant non-execs with boards and with wards. And actually we are using this week as part of our April 4 framework, the board rounds. So we're not doing knee-jerking different reactions. People are going to board rounds, people are doing the check and challenge. And we actually got quite a few more discharges yesterday than we would have normally done on Tuesday as a result of using this. There's a raft of other things there which we know we need to do. 7-day service is obviously crucial, having talked you through the weekend discharges. But just to kind of center in on that one there down the bottom right, TTOs, this is really down to kind of 5 reason and compartmental. You've got prescribing, the time of prescribing, the ability for a junior doctor or a prescriber to be around to prescribe, getting that prescription to pharmacy, getting that prescription then made, and then don't underestimate the ability for us to mess up, essentially getting that prescription back to the ward. And even if it is back on the ward, then making sure the patient gets it. You know, from my own experience, I've not here another hospital where they're looking for my prescriptions for ages, and actually it was in the bedside cabinet the entire day, ready for my discharge. They've done all the right things, but they couldn't find it. So, and I don't know whether that happens here, but I'm sure there will be cases. So there are multiple parts of that pathway. So, Andre, coming back, I think it was you, coming back to your point around how we unpicked it. We know where some of the issues are, and it's actually at every stage across the pathway. And when you look at when do we discharge, it's not early enough. When do we plan for discharge? We don't plan for it the day before. But when you go around, which Heidi done and Matt's done several times, you talk to some of those junior doctors, they are slammed every day just doing the discharge letters of that day. Trying to get them working a day ahead is very difficult. So we're working around how else we support that workforce. Discharge lounge is another key you all mentioned. And I think that's crucial. However, we do not have one at the moment here. If we do get the ability to get an urgent care treatment centre up and running on site, we'll then be able to then get a discharge lounge. But at the moment, space is an absolute premium. So the last slide for risks just shows you again where we are in terms of national position. We are not in a good place. We have over 50% of our patients over 7 days, over 20% over 21 days. Where is good for us to get to realistically? We know we can get good flow if we can get under 100 patients on our super stranded. We know we can get a good flow if we can get back under the 250 mark on our stranded. That would not be where we would stop, but that is where we aim to get as quick as humanly possible. So the aim is to get there by May, and then November, we want to be reducing that down to where we're actually in the top quartile of the country when it comes back to those model hospital figures. The risks to this there are quite a few. Obviously, COVID at the moment, we have just over 100 patients now back in our wards. We've got 4 wards, including the Eleanor ward, our frailty ward, which is now COVID positive. We've got 150 people medically fit for discharge on any given day, not leaving the organisation, which I've gone through, of which 70 are waiting over a month. We also have 25 to 30 patients beds which are blocked, because when we have a pop-up, as in a positive person in a bay, we then have to close that bay to anyone else being admitted as we go through a 7-day exposure. We are trying to combine those as much as possible. However, some of these areas you cannot backfill, and some of them are on COVID, so you can't just put anyone else in there. So on any given day at the moment, we are acting with around about 200 beds less than we need. And that would solve, when you put that together with the 7 discharges less from A&E, that would give us the space we need to move on any given day. However, we need to get there. I won't go on any further. I think I'll probably labour the points, made most of the actions we're taking across the whole trust. But I think it's just more for assurance that there is a lot of work going on outside the trust, and a lot of fingers pointed at outside the trust, and there is, rightly so, a lot of delays to move our patients outside the trust. However, internally, that doesn't stop us from really driving forward, making some of those changes. As you can see, there are some structural things which are getting on our way, which are not allowing us to move forward, despite the good efforts of our nurses and our medical colleagues. Questions?
Okay, thank you, Palmer. That's a very good, probably the best analysis I've seen for why we have a persistent problem. Rachel and then Jill.
Thanks, Palmer. That was really comprehensive, and it's good to see some proper root cause analysis in there as well. It's clear we're in a different place to KGH. Do you have is there any sort of overriding reason why, in your opinion, or is it a collection of smaller general?
I think that there are some isms about being on the west side of the county. Absolutely. However, I think there are discharges, some is massively a sum of its parts. And that's why, if you were going back to that slide with all those different parts in there, if you were to do one of them, it won't make any difference. So we can just do board rounds. It will make a little bit of difference, but not much. Actually, we need to get at least 10 of those things up and running. That will then make a difference. And only then. So each one's not linked to 1%. It's only when you get 10 where you get 10%.
And are KGH just generally doing all of these things, and that's why they're in a better position, or what can we learn from them?
So there are a few isms which are different. So when you look at the shrewd data for those that live off it, in terms of what's going on across the county and where the pressures are, they have more minors in their A&E than we have majors. So on any given day, you can probably take it as almost an opposite effect. So whilst we may both have 100 in the departments last night, they will always look better in the morning because most of their numbers are minors and they can turn them round. So there's that for a start. Ambulance handover delays, they have more physical space to soak up and offload and cohort patients from ambulances. So they could get a halo, which is I forgot what it stands for off the top of my head now. That's an ambulance liaison officer that can come in and basically look after 2 or 3 patients, releasing 2 or 3 ambulances back on the road. Whereas we don't have that capability. If you offloaded there and tried to look after 3 people, you wouldn't be able to move in our offload area. So there is some isms to ED. There is some isms to what comes through their ED on any given day. But in terms of their discharge, they are a bit further ahead than us in terms of being able to get some of the actions up and running. Their frailty service they have more frailty conditions than we do, which is why we're trying to, thank you, Simon. So they're able to actually look after patients a different way, which is what our business case are trying to address. So
Okay.
Yeah. Hopefully that answers your question.
No, thank you.
Let's just collect some thoughts now. So Jill, then David, then Elena, please.
Thank you, Chair, and thank you, Palmer, for a really good paper. And I think it's really exciting that we're on this pilot. So I think this is a real opportunity for us. So I'm looking forward to hearing more as time goes on. I've got a few things, if I may. Within the paper, there's something about a business case for more staff to help along the discharge pathway. So I'm imagining that's an increase of discharge coordinators, because we've been talking about that for some time. And the business case has a timescale of 22-23. So I wondered if we could kind of expedite that so that if we need more discharge coordinators, we recruit to them as quickly as possible. It would be good to hear a little bit more, if we can, about a frailty trolley, because that kind of worries me, given the connotations of where we used to stop trying to put patients on trolleys and now we're trying to put them on. So a little bit more detail around that would be really helpful. And then I was just wondering about communications. So I don't think the general public, this will be tricky, but I don't think the general public realise the implications of patients staying in hospital longer than necessary, about how they can become deconditioned and may never recover their previous mobility. And I wonder how we can kind of get that over, because generally the public will do a sigh of relief when the patient's in hospital and say to each other, well, of course, they're in the best place. Well, they aren't necessarily in the best place because they could potentially recover better in their ordinary place of residence, whether that be home or care home or wherever. So I wondered if we were thinking about how we managed public expectations. That might be across the system. It might be in the form of a leaflet, discharge leaflet when patients come into the hospital. And also our responsibility as a system, thinking about communications to the general public about keeping well and active to prevent coming in the first place. So comms, I thought, was probably quite an important part of that. Thank you.
Thanks, Joe. David?
Yeah, thank you, Chair. Yeah, thank you very much, Palmer, for a very detailed and technical analysis of the situation that we find ourselves in. Just a very quick question on your conclusions. And you say on the 22nd of March, a meeting was convened with senior system leaders to agree on the 3 high impact interventions that will make a difference for winter. Be interesting to know what those 3 high impact interventions are, should they have been determined. My second question was about community beds, and are we kind of developing the fact that we could in fact manage more community beds as a hospital? Is that one of the solutions that we're looking at in order to reduce I think it was the grey areas that you outlined in your analysis? And how does this play into vertical integration and the future of our trust and our group in managing more community medicine rather than just acute medicine, or community care rather than just acute medicine? And my third point would be the one Simon mentioned earlier, is about the publicity which the AI initiatives in 100 trusts have been given. It would really be great to see ourselves a part of that that initiative.
Thank you. Irina?
Thank you, Alan. Thank you, Palmer. Actually, your paper I find your paper very optimistic. At least I've got this impression when I was looking at the chart that out of the 34 days, 25 days are within our control, and we are able to influence it without drawing help from the system. So I really see it as a very positive outcome from your analysis. Two points which I would like to make. You've mentioned that at least 5 patients a day admitted, and the admission could be questioned, let's put it this way. Do you think it's somehow related to the profile of the doctors and consultants working in A&E, their age group, their experience? Are there any correlation? And second question, when we're looking that there are so many stranded and super stranded patients in our hospital, is there a connection that there are greater ratio of these patients involved in serious incidents or falls? Because yes, the data proves that staying in hospital is detrimental to health. It's not helpful. So yes, these two triangulations, if you can. Thank you.
Okay, thanks for that. I'll finish up with you, Palmer, but I'll go through some of the other hands that are up. Can I just make the point for you coffee lovers, you're about to lose your coffee break. Heidi, then Becky, then Teresa, then Simon.
Thanks, Helen. So just to follow up on, I won't follow up on the community point because I know Simon will probably be following up on that. To follow up, overall, I just wanted to give the board assurance that whilst we're understanding the problem better, we need to make sure we maintain that grip and start to make the changes. So we've got an urgent emergency care board within the hospital that I'll be chairing to support Palmer and colleagues in making sure we keep the right focus on this work. Equally, we're working closely with Becky around some of the ICANN initiatives to make sure we support in every way we can. So from an oversight perspective, we're increasing the oversight and getting even more scrutiny from external peers than we're getting even through the discharge, so that we really use this as an opportunity. Interesting that I'm sure Debbie would want me to rebalance this KGH's fine narrative, because I think, they're very pressured too. But I asked Debbie myself, because obviously she'd worked here a long time. And as Palmer said, they've got an urgent treatment centre in that side of the county. They have a larger physical space, so they still carry the risk of holding patients, but they might not be in ambulances. And so they've had some ambulances this week as well, but they are definitely in a better position for ambulance handovers than us. So we are supporting each other as much as we can on that and learning from each other. But there is some really interesting data we're looking to unpick in terms of why do they have more minors than us, etc. So just to assure the board, we're using the benefits of the group to make sure that we unpick and learn from each other. I'll let Palmer come back on the frailty trolley. The only other thing I'll pick up, Alan, really was two things. The comms, really good point, Jill. I've discussed this, and so has Simon, at a national level in terms of managing that hospitals aren't always the safest place. They are if you need acute care, but not if you don't. And equally, the other point you made around on admission, if we go back to the away day where we talked about health inequalities and those teachable moments, Debbie and I have been talking about what education can we provide patients on admission, because you're more acutely aware of your own health on admission. And so what do we do internally? So that's something that we've picked up there. And in terms of data, Matt and I are continually looking with Debbie at are there increasing SIs or even incidents in ED, for example. The last time, Matt may want to come in, the last time we looked, there weren't. That in itself is one indicator, but obviously we need to make sure we're talking to teams, because sometimes when they're busier, we need to make sure things aren't being normalised. And I'd say they're not, because they're being escalated and we're supporting the team. So just, I won't come back on them all, Alan, conscious of time, because I know others want to.
Thanks very much. Becky and then Teresa, can we keep it brief, please? We are running heavily over time here. I know this is interesting, but...
Yeah, no problem. I just wanted to really support Palmer. I think it's a really excellent exposition of all of the issues, and some of those have been well known through ICANN, but ICANN does not cover the whole of our urgent emergency care pathway, and what Palmer's put together absolutely does. And I think the focus of the ICANN work and the restructure and the refocus on the short term, what's going to make an impact for winter apps. Palmer and I have been talking a lot about how we can really strengthen the governance and oversight, as Heidi says, over this piece of work. And as we look in ICANN to make what has been done sustainable and just part of the way that we work around here, the other two bits that ICANN will be really picking up and supporting in this is refocusing on frailty front door, which we've had to pause slightly because we've been having to bed the units over winter, that we'll now be able to pick back up again, and really focusing on the community provision and that away day that Palmer's mentioned around the high impact things that the community and our system partners can help and support us with ahead of winter. So support for Palmer and everything is put together, and obviously ICANN will help where it can.
Right, thank you, Teresa.
Thank you, Chair. Just a reassurance point, we are working across both trusts on some discharge communications, and I'll ensure that the point around deconditioning is included. We work closely with system colleagues on this as well to make sure that messages are spread far and wide. And we will also be promoting healthy lifestyle activity later on in the spring, particularly around national fitness days and things like that, particularly with relation to the pocket park that we have at KGH and similar facilities that we have at NGH.
Simon.
I've spoken to Leslie since the visit. She commended the work that is going on, first of all.
That's this, by the way, guys, just to clarify that. Let's see.
Thank you. The next visit she wants to have with us all, probably in May time, is a system visit, because she said, while it's helpful me talking to you as a hospital, I need the Mental Health Trust Chief Executive, I need the ICS Chief Executive, I need the whole system in the room, so that we can start having a combined conversation about how we're going to shift this problem together. And if colleagues are interested in being part of that visit, I'd be very happy, because I think this is a time when we all need to bind around this as a system, to say this is a problem that collectively we need to solve together. So the key message from her was keep up the work that you're doing, and also be prepared for a system visit, which we will host, but which will bring together all our partners. And I'd be delighted if non-execs were interested in attending.
Okay, thank you very much. Palmer, do you want to wrap anything up there?
Yeah, just I think just coming back to what we've talked about before with Andy and the team about the care record will make a huge difference, because when it comes to those 5 patients a day, knowing that people have something already on their GP record, or they have something at home because they may not be able to tell them, will go a long way and actually give clinicians that, again, that warm fuzzy feeling they can discharge people, and they will go into the place where they are best kept safe. In terms of the just those 3 top things that David, I think you asked about, pathway 1, we are doing much more of a discharge to assess model, working to a place-based theme, which is different from what we do now, ever so slightly, but it will make a difference in terms of the speed to get people out. Pathway 2, combining some of the establishments to actually, again, talking about that staff, but there's no point in having half open areas, actually combining to have fully open that can really push the boundaries of what they can admit and then discharge. And then the third one is end of life care, which there are relatively few in the grand scheme of things, but they soak up a lot of resource, both in terms of while they're here, but also trying to get them back to their usual place of residence, wherever that is. Actually, it's not a good experience here for them. The only reason they end up staying here is because we cannot actually transport them anymore, because it might be when it could happen. So very conscious we are trying to get back to that patient experience bit for them, because actually it's not just them, it's the whole family. So yeah, those are the 3 key areas we're going to focus on.
Okay, thank you very much, everybody. And that's been a good session. I'd like to ask the performance and finance and the quality chairs to think very carefully about whether they can improve the metrics they use in the SPC approach to these kinds of issues. If this is our biggest problem, then we ought to be focusing on those things in the performance reports that come before those committees. And we've been through that today, the whole IGR, which metrics can we get right? But clearly, if we can begin our focus on things that really matter to us, and this is the thing that underpins everything, then that would be significantly helpful. I'm interested in a non-exec champion for the discharge processes. If anybody is interested, please talk to me. And finally, reiterate Simon's suggestion that our request that the non-execs are invited to the day not yet determined in May. And I will be making sure that invitation is extended to ICB non-execs and NHFT non-execs, because I think sometimes people get a filtered view of what their trust or organisation is doing, and this will expose everybody to a data analysis. Right, thank you very much. You're heavily overrunning, so you've lost 5 minutes of coffee break. You've got 5 minutes. If you could be back at 11:58, that would be really good. Thank you very much. Okay, everybody, 11:58. Okay, system operational plan. Now you'll note that we have a longer session on this in the private part of the board, so perhaps you could bear that in mind when we're running through this section of it, in order to see if we can perhaps catch up a little bit of time. Anyway, I think this is Karen and John, I believe. Who's starting off? Karen, you going first?
Thank you, Chair. I'll go first. Thank you. So attached is a paper which summarises the draft system submission, which was made on the 17th of March. This is the submission across the system for the operational plan for 22-23. As we've already discussed earlier, or Simon mentioned earlier, this is the first time we've done a planning round in this, well, the first time we've done a planning round for the last 2 years. And it's very different, the planning round this time, because it's obviously a system plan. We're going through system structures in order to develop our plans. And also will be held to account, and success will be judged collectively across the system. So really important messaging, and it's been challenging for all systems, I think, to produce the plans this year. A lot of hard work has gone into it. The key things I just wanted to say is that as you know, we are looking at the key national planning asks are around delivering our elective recovery, and that's the focus of the discussion we'll have later on, as well as delivering a break-even financial plan. Clearly, there's real tension in those two asks, because as we've talked about before, there's cost in delivering that elective recovery. We as a system are starting in a really fortunate place. We've talked a lot about that earlier already in terms of our current performance and delivery for our patients locally. And that's a really important point to raise. And we've heard and how we are one of the leaders of the across the region around our delivery, which again is something to note. However, our biggest challenge is around the finances. So the key points raised in the paper, just to note, is that we are in a good position against the elective recovery. We are one of the only systems in the region that we will not have patients waiting over 104 weeks, 78 weeks and 52 weeks. And we're really aiming to reduce that further for our patients locally to reduce the waiting times. We will be delivering against our cancer standards and continue to deliver those, which is excellent news, and we'll continue to be ambitious in our outpatient transformation. Again, really positive news. With regards to the workforce planning, initial workforce plan has gone in, more work to be done in terms of there's a workforce summit plan to stress test our investments and to really triangulate our workforce plans with our activity plan. So that's the work that's still ongoing. And then the final message really is around the finances, which, as we know and we've heard, as you have read in the paper, we're not going to be delivering a break-even position. We've posted a deficit position, as have other systems nationally. All systems have posted a deficit position. And really the discussion and the work that needs to be done now is around balancing that tension between investments, delivering our elective recovery, delivering our performance, and how we manage the financial position in that. And there's ongoing work, and John can pick up that, but there's ongoing discussions and work to be had, in particular around the transformation, managing our efficiencies, and really looking at that balance between the elective delivery and the financial position. Just the one final point I want to note before I'll hand over to John, if you want to add anything around specific around to what I've said, is that this obviously, as I said, is a system plan, and we can't, and listening to Palmer, well, with the discussion we've just had, we're not going to be able to deliver our part of the element of, our aspects of delivering the performance and our operational performance without our system partners. We've got to do this together, and it's very much around working together across the system, across with our primary care and community colleagues to deliver our plans for next year. Hence, there's a section on that too. So I shall pause there, mindful of time. I'll hand over to John if you wanted to add anything more, and then happy to take questions.
Yeah, happy to. Thank you. Thank you, Karen. So I think, Karen's articulated the tension that we've got. I'll reiterate that the intelligence that we've been given is that no system has presented a break-even plan as part of the draft submission. So the challenges that we're seeing are absolutely being felt nationally. The ask on the money from the planning guidance anyway was extremely or is extremely challenging. Just to kind of restate kind of the two or three big assumptions there. One is that we exit any and all COVID related specific costs or disruption as we move into the new financial year. And we're aware at the moment that we're still seeing significant challenges around our response to the existing IPC guidance and segregation of pathways, etc., and the impact of that on kind of pop-ups, i.e. patients that flag as being COVID, and what that means for then remaining beds. There are specific challenges, assumptions around activity growth, and I'll be completely honest and say we will not, as a system, based on the allocation that we've received, get any growth money to pay for more activity once you've adjusted those numbers for the costs of inflation and the must-dos, the Better Care Fund that we are required to put further investment into, and the Mental Health Investment Standard, which is a requirement to continue to increase money and allocations to as a system. So once those things have been taken into account, we are not left with any funding to pay for activity growth. However, the expectation is that we deliver 104% of elective activity compared to 1920, and a myriad of other increases in activity, 120% of diagnostics, etc. So the money allocation and assumptions and the operational ask, when you put them side by side, do not align. And part of the challenge that we're going to have as we work through this planning round, individually and with system colleagues, is how close we can get to those things, balancing off, and the conversations that we need to have around those trade-offs. I'll reiterate that we are in a very good position when it comes to operational performance, and certainly compared to what we've seen from other systems, that is a good position to be in. That is something that we need to leverage in conversations, and indeed start to have conversations about trade-offs between that and the money, because part of the reason we're in a challenged place on the money is because of the capacity that we've got in place to deliver that operational performance. And clearly, if you step back and take a look at it that way, you go, that sounds eminently sensible and pragmatic. However, we are having siloized conversations, and we need to work through, both in our private board session and then at a system level, how we go back and attempt to balance those issues off.
Okay, thank you very much. Anybody else contributing to this, or are we opening to discussion there? Opening to discussion. Okay, thank you. I think I've said before about this that obviously it's in our patients' interest that we get our performance as high as possible. Obviously, we have a responsibility to balance the money, but I think as an opening position, we ought to be aiming for upper decile performance and below average situation on the money. Now, as John says, that's difficult in a silo conversation when you're trading off, but the NHS regionally and nationally, thinking just today about the public expectation, public view, the NHS nationally and regionally need performing trust to do something significant about the waiting times. And whilst I recognise that these costs are there, 104% of activity, we should really be able to do that if we got our theatres working efficiently. And I know that's a transformation project that Becky is leading, and others, and equally our outpatient activity transformation project. And if ICANN delivers, then those numbers should all be doable, which means it is both a responsibility for us and for the system to make those things happen. So that's an interesting and difficult conversation at the Integrated Care Board in April as we go through this. So, remembering we have a private session on this, does anybody want to add anything at this point? David.
Yeah, sorry. Just very quickly, and thinking about good stewardship of public funds and so forth. Your slide on efficiency, doesn't really direct us as to where you think efficiency saves can come from. And I suppose you'd be the first to admit, John, Karen, that there must be efficiency saves out there, and Becky. But where do you think we'll get those from in 22-23?
Shall I pick that one up, Chair?
Please.
So a combination of things, David. So I would expect, so we have a number of programs that have been referred to even in this meeting around improving our use of clinical capacity. So we have a program around improving outpatients. We've procured a new system that will help us schedule and manage outpatient capacity far better than we're able to at the moment. And that's in the process of going live now. We have a substantial program working on supporting improving our use of operating theatres. Again, very much a focus on improving data to improve those decisions and utilisation. And I would expect there being a basic level of kind of cost control and budget management, given where we are now as we have moved out of the real depths of the pandemic, I hope. And I think a combination of all of those things, as well as reassessing the capacity that we've put in as a result of COVID-related compliance, looking at where we are in terms of our use of temporary staffing, all of those things, as well as procurement discounts, pharmacy improvements, etc., get you to a place internally, and I'll get onto external in a second. Internally, get you to a place where you have that program, and I think that as a board, we need to have conversations about how much of that is kind of reusing capacity that we've got in place and don't want to use to be able to treat more patients, what that means for additional costs of kind of waiting list initiatives and outsourcing, but then internally, whether or not we need to kind of tighten the belt given on certain kind of basic cost control and budget management type issues, given the relative relaxation, certainly from a national view, a relative relaxation of those controls over the past 2 years. From a system level point of view, we have signed up to and invested our part into a development around ICANN and support for our kind of frailty and over 65s. There is an expectation there that through that program, there is a more efficient use of our beds, and that we will be able to divert patients to more appropriate care settings, not in an acute setting. And we need to work through again with colleagues on whether or not that means we are able to recycle or essentially take the pressure off of, and we've heard in terms of certainly ED and urgent care flow, we have major pressures NGH around flow. So we will have a decision to make around, does that then make us more resilient and able to operate more effectively if there's a bit of a release valve on that capacity, or are we able to do something around exiting costs, in particular premium costs? And I think that's one of those conversations we need to have. I'm comfortable that in terms of overall program, the programs are there. I should also probably talk to we are investing well but heavily in digital infrastructure this year. Colleagues would have seen the multiple millions that we've been successful in procuring in terms of funding for digital. We need to ensure from a benefits realization point of view that drives cost out. That doesn't solely sit with our digital team. Clearly, it's going to be the operational and process changes that we're able to leverage on the back of doing things in a more automated, streamlined, non-duplicated way. So it's all of those things, David, as well as agreeing with our system colleagues where we have ongoing challenges with how we use our resources more efficiently, on how they can help us with those conversations, in particular beds, flow, timeliness of assessment for patients in kind of vulnerable settings, etc.
Okay, thank you, John. I mean, I maybe should have decoded my comments a bit more, but I'll finish up after Simon about how we ought to do this. Simon.
David, the biggest thing right now, resolving the contradiction between planning guidance, which assumes we're in a post-COVID world and essentially are free of any shackles, and an operational reality where IPC, infection prevention control guidance, still shackles us very, very considerably. We've got a direct, and if I talk to my colleagues around the country, we've got a direct contradiction between an elective activity ask which says do more and essentially do it in a construct of pre-pandemic, and IPC guidance which remains in a pandemic setting.
Okay, thank you. My comments were meant to make the point really that the transformation programs taken together with ICANN paint a picture of an organisation which should be admitting fewer people and discharging more people more efficiently. And that's the essence of Palmer's paper, and that's pointing to our committees to look at those metrics very carefully. And the two transformation areas of theatre utilisation, which we're pretty poor on, offers a significant opportunity to get towards the 104, get past the 104% without having to spend extra money in the independent sector to hit that number to get the rewards. So it seems to me that we shouldn't just sit there looking at what's difficult today. And I take Simon's point, we should work on the assumption that these changes will come through in an appropriate time in the year, and we should aim to maximise the benefit of the transformation programmes that Becky is leading, both in her contribution to ICANN and what the system has to do, but internally in our theatre and outpatient transformation. Taking those together, that presents a picture of an entirely different type of hospital activity. And I think that's very similar to what John said, so I'm glad we're on the same page. Right, thank you very much, everybody. We'll talk more about that in the private session. Group communications framework. Mark, Teresa.
Thank you, Alan. And yeah, I was just going to introduce us to the first of these two items this afternoon now, as we walk through them. So Teresa will take us through the communication strategic framework very shortly, and then I will lead a presentation with regards to our people plan, followed up by Emma, as you rightly called out at the beginning of the agenda, joining us to take us through a bit more of a journey on where we are with our volunteers, obviously more specifically at Northampton, but across the group, and some fantastic work that the team there have been undertaking in the last couple of months. And as you rightly pointed out too, and we'll do it when she joins us later, the successful appointment of Emma into that post will only help us go from strength to strength in that area. We're also joined from the communications strategic framework perspective by Alicia O'Donnell-Smith, who's our head of communications working within Northampton. You colleagues may remember Alicia came to the non-executive session a couple of weeks ago to talk about the outline of the strategic framework that we're about to see. Before I started or hand over to Teresa, one of the things that I want to do is obviously just reference what people have referenced today. It'd be really strange for the Chief People Officer not to reference the staff survey, given that the results have come out today. And we do have a lot of work to do in the organisation, as Heidi's email has pointed out, being sent around to both at the hospital today, to all staff. We've got some work that we really need to undertake to focus on how can we improve the experience of our colleagues. And clearly, as we talk about these are not mutually exclusive agenda items, which has also been pointed out today. The impact that we can have on discharge and freeing up some capacity to create some time can then create time to manage and to support colleagues, and not lead into people feeling so pressurized with regards to work. Denise pointed out earlier, quite rightly, that we do have some fantastic psychological support services in our hospital, and we have been able to improve those. It would be really great if we didn't need to have them sometimes, and therefore we could be more preventative around people not feeling that they need to utilize those services in the first instance. So all of these elements come together, and obviously they'll come together on the 29th of April, where we need to really work on what our cultural improvement program is going to be across the hospital over this next year and beyond, perhaps, because it will probably take a significant period of time to move on from where we are at the minute, also considering the situation, as we've already articulated earlier on today, with regards to absence and so on and so forth too. So if I could lead firstly into the comms strategic framework with Teresa, and then I'll come back on the people plan presentation shortly. Teresa.
Thank you, Mark, and thank you, committee. So I have a presentation that I'm happy to share with you after this meeting, but I'll talk through it for the purposes of brevity. Within the communications teams across both trusts, we're at the beginning of a journey. As you will be aware, we came together as a team this time last year, and that's not been without its hiccups, but we're working through those at the moment. And it's good that we're at the beginning of a journey at the moment, because also communications is going through a great deal of change. There's been a lot of research in communications over the last decade or so, with movement towards how people can engage, how organisations can engage with their colleagues better. And we've looked at this research and we've really embedded it in how we're going to work with colleagues to better engage. We will also want to make sure that we engage better with our external audiences as well. And how we're hoping to do this is to integrate a more listening and two-way communications model. It sounds obvious, but communications that land better are when they are in a one-to-one focus, when you're talking to somebody that you know and trust. So to be in a position where we can bring this into our communications with both our internal and external audiences is a bit of a challenge, but it can be done. And that's what we'd like to do. We're working at the moment to implement how we can change our ways of engaging with colleagues. At the moment, a lot of our communications is very digitally focused. And that's no flaw of the organisations. That's very much how communications are delivered. When the world went digital about 20 years ago, a lot of the more old-fashioned considered ways of engaging were ditched, things like posters and face-to-face engagement and leaflets. And actually, if you're not sitting in front of a computer all day, these are great tools to engage with. So we're looking at how we can reintroduce these across our trusts, both for our colleagues and also for people that come into the hospitals. What we'll be doing, though, is bringing those physical assets towards a more digital offering, using things like QR codes. We're very aware that most people have access to digital tools, so they will have mobile phones, and we're going to make sure that everything we do can be accessed physically as well as digitally to ensure that people can access it in a way that works for them, so they can see that it's accessible and they can have things that are spoken if they have other issues with obtaining data. We're going to look at doing more first-person accounts as well. So one of the things I've picked up working here is that patient stories are incredibly powerful, but also our colleague stories are incredibly powerful as well. So what we're going to be doing is introducing more first-person accounts into our communications mix. And this will help bolster the communications that we do to support executives and leaders and the board across the organisations as well. We're going to be moving from a more the transactional tone of communications that's been necessary during the pandemic. With a crisis, a lot of people seek information. Again, that sounds obvious, but it is something that we see. And we saw people that would engage more with our social media, both internally and externally. And we saw more colleagues engage with our communications than we would necessarily see over a business as usual period. We don't want to lose that momentum, so we're going to make sure that we capitalise on that. But the tone of our communications will become less transactional and more, let's have a conversation about something. And I'm going to start to wrap up now. So just a couple of things I want to mention. We will be doing some work with the board to improve how we get your messages out to colleagues. I'm very aware that you want to communicate some of the work I've done to develop this plan. Everybody I've spoken to said we really want to make sure NEDs and other members of the board are seen across the organisations. So we will be working with you to see if there's anything we can do to help improve or put in place some digital reach for you, such as social media accounts. We'll also be doing some work to promote all the work you're doing in the hospitals as well. So David mentioned earlier on that he'd been into NGH earlier this month, and that'd be really good if we could promote that via some of our channels. So next time you're in the trust visiting, please let comms know. We might be able to send a photographer along. We might be able to mention, or we will definitely mention it in the newsletters as we go through our regular channels. And finally, we have been sending you our news email as well. We get a regular daily news email that's got all of our broadcast and print media on it. We've been sending that to you. I'd appreciate your feedback. If you're welcoming of it, that's great. If you don't want to receive it, that's good too. And finally, the last thing I'd like to say is one of the things that will really improve our communications offering is some intranets that are accessible via all tools. So at the moment we have 2 intranets. They don't link, and if you work in one trust you can't look at the other. They are out of service and they don't support a lot of the modern engagement tools that we'd like to see, such as video or engaging infographics. So a lot of our communications at the moment tends to be quite operational, and we have to put a lot of information via channels to tell people how to do their job. What we'd like to see in future is being able to put a lot of that information into intranets and then directing people towards those intranets using the communications channels such as email and events such as group briefings as opportunities to really engage and connect with staff. I appreciate there's a lot of money that's needed for the intranets, and we'll be working with Andy's team to see what we can do to get those in place as we move through the year. I appreciate that's a bit of a whistle-stop tour, and you've probably got a few questions, so I'm happy to take any questions at this point.
Any comments or questions? Jill and then Rachel.
Thank you, Chair, and thank you, Teresa, for a really clear communication strategic framework paper. Excuse me. Some great stuff on internal communications. I was just wondering about external, because it's of course really important how we come across in the media. We want accurate media cover, of course, and I know that's reliant on relationships, but I wondered, as part of the metrics, whether we could measure positive and negative media reports, because that will tell us how well we're managing the media. Because, as I say, that's really important for our general public and for our staff, that they get accurate information, and then hopefully that most of the reports are positive about the hospital. And then secondly, going back to my theme of healthy messages, whether we could make sure there's a focus on that, not only for our staff, but outwardly facing. Thank you.
Okay, thank you. Rachel and then Denise.
Thanks, Teresa. Completely acknowledge it's a framework, and some of the detail, or the detail is yet to be produced. I was just wondering when we might be able to have a fully comprehensive strategic comms plan that supports a number of our key strategies. Is it something that we'll be able to see imminently? I think, you know, apart from discharge, the other theme of the day is comms, and it's absolutely vital to ensure we deliver these strategies. Thank you.
We'll come back to that. Denise?
That was one of my points. So thanks, Rachel. A couple of other points, one of which is related, that when we had the presentation on discharge, I put a comment in the chat there that I think that the communication of key issues like that, and in this case around discharge, it's really important how we communicate that to staff, because I know from the reverse mentoring that I do, the some of the messaging and the way that it's just kind of the same message every time in the newsletter, and the feedback from the staff is, do they think that we're not doing everything that we can anyway? So I think, some of this context and different messaging and helping people to understand why is also really important. And the final query was that I've heard on a number of occasions about how important the WhatsApp groups are in terms of communication, because of the fact that so many people only have access to information sort of via their mobile phone during the day. But conversely, at the last away day, we attended the data management training, and WhatsApp groups were being actively discouraged because of security of information. So I think that's probably a very detailed point, but I just think that there's something to be done there, because I think if we took the WhatsApp groups away, that would make communication even more difficult. So I think we need to think about the messaging there. Thank you.
Okay. Becky.
I just wanted to pick up around some of the things around actually putting this into action and implementing it. You've obviously called out around the intranet and making sure there's funding for that. I think some of the other things are included in the paper, aren't they, in terms of the prioritisation framework and being clear around what some of those things are. But what else? Are there any other kind of key risks to delivery for this, and are there any other things that are real enablers that you need in your team, or you need from the rest of us, so that we can have a much more comprehensive communications function in line with this framework in future.
Thank you. Rachel, is that an old hand? Yeah, okay. Heidi.
Thanks, Chair. So thanks, Teresa, really helpful. I think it's really important for me to acknowledge as the hospital CEO that our comms isn't where it needs to be, and aligned with your narrative at the beginning, Teresa. This is the start of a journey we're all on together. And to Rachel's point, that we now need to develop what this really means for how I engage with teams in light of the staff survey, and how the executive team do, what our overarching framework really means in that context. So I guess really, Alan, I just wanted to assure the board that I think it is important, the first point that Teresa made, that this is a start of a journey, but we do need to flesh it out given some of the transformation, some of the challenges we have around how staff are feeling and how our teams are feeling. And some of this is about how we engage on a personal level. Some of this is through the framework of overarching comms. We've been having some really meaningful and robust conversations amongst ourselves in terms of what is our collective responsibility to making sure we've got a really good comms and engagement offer. A bit like the digital conversation earlier, it's a big piece of work, and it's essential that we get it right as an enabling and ongoing fundamental part of anything we're doing in the hospital. So whether it's responding to the pressures, whether it's talking about transformation, etc. So we are all committed to, in the immediate weeks, working on what this needs to look like and what it really means.
Sorry, Simon.
So just to respond, thanks for the comments. I own that this is, I think, to the start of a journey. To respond directly to your point, Rachel, I think we need to publish pretty promptly within the next 4 or 5 weeks what our aspirations are across the next 3 and 6 months, to start to turn this framework into a series of things that we can measure and monitor and start to understand. So I accept that as my responsibility to try and work with the team and Mark to do that. I think a couple of other points. There is a big system, Jill, you've raised it twice, I think, so I just want to respond directly to it. I think there is a big agenda for system comms, which at the moment is quite disconnected from the purpose of the ICB. It is out there and it's quite well resourced, but I think we need to link up with it far more strongly as we develop this, because your point about healthy messages, that is a hugely collective response for all of us, not just in the hospital. And my sense is we haven't got our narrative as a system on what that should look like. And I think it's something we should take back to the ICB. So it's not an insignificant resource that they've got, and we need to join up with it. The other point that I would make is, as Heidi said, comms is a collective responsibility. And we need to work out, as we do some of our management development in the year ahead, what we would want everybody to be able to do as part of comms, not just the comms team. But to the very narrow point, the challenge, I think, is clear that we need to publish some metrics that make clear what we are going to do, and some deliverables, and those how this has to be tested. Thank you.
Thank you. Teresa.
Thank you, Simon. So to come back on some of the detail of the points raised, with the external media point, within the measurement section of the plan, I do talk about measuring external media sentiment. This is something that we're going to put in place and report on monthly, the sentiment of the media coverage we've published that month, and also whether our key messages were contained. We tend to be quite robust. If there is inaccurate reporting, we do tend to go back to the journalists and ask them to correct it. It's good practice to do that. I won't go into the point about for the strategies, as Simon's covered that off. The point around discharge communications that Denise raised, one of the things that I'm really keen for us to build into this plan is a constant feedback loop. So if things aren't landing with staff, if we hear that, then we can change the messages that we're putting out. And that's something that I really want us to develop within the organisation. Feedback to communications tell us what's not working and what is. One of the lessons I learned talking to other trusts is try everything, and if it fails, don't put it into your plan, and if it succeeds, keep it until it stops working. Communications is an ever-moving feast, and we're really happy to employ that kind of methodology. With regard to the WhatsApp groups, if the WhatsApp groups are being discouraged, we can look at other channels to engage as well, such as the face-to-face forums that we understand that take place. The points raised about key risks. At the moment, we're carrying a number of vacancies in the team, so I'd like some, we'll be able to recruit to those vacancies once we get into a position to do so, and that will really help us develop the plans and the communications that we need to do. And the other point I'd like to raise is, as I've said, this is a beginning of a journey, so we will be learning and developing as we go. So patience as we go through that, and please feedback to me, forgive me, feedback to me as to how things are going, the good and the bad, and we'll make sure that our model is nimble and can adapt to what we're hearing. But thank you for your time.
Mark.
Thank you, Joe. I was trying to work out about how to do the hand on this particular platform. So just to pick up a little bit on some of the detail to Denise on the WhatsApp position. So it's the confidentiality. So it's the patient level detail stuff that you definitely don't want to obviously be sending on those channels because of the nature of them. I think that's really important. We need to consider what messages we put out there. I also really wanted to pick up particularly on Heidi's point around how we do communicate and how we do that locally. It's a real balance, and it's something that struck me in the, as I say, in terms of the people committee around the health and wellbeing aspect that we have as an organisation that we can't forget. Just a year ago, I announced that at NGH we were the Health and Wellbeing Organisation of the Year, and we've got a huge amount of work that we undertake from a health and wellbeing perspective. But if it's not picked up and adopted locally, if it's not embraced locally, it really doesn't really go very far. It's great to have a lovely menu, but if we've got nobody at the restaurant, there's nobody ever ordering anything. And I think that's something that we need to do around the biggest risk I would suggest is picking up that point around how we make sure that we acknowledge, of course, we've got a communications function and experts working within the team to provide us with guidance, of course, but that communications is everybody's business in the organisation. It's really important that we help to support and educate people to do that. You know, I have the ability of seeing some of the things that come into the team in terms of we need comms to do this, and it's like, oh, that's a message. You can talk to your team about that, as opposed to it being done in a slightly different way. And again, going back to the staff survey, I think what those results have shown me, there's a number of lessons to be learnt there, but equally it's that connectivity with people that you work with locally on a day-to-day basis. That's where you get the real trust from, which we can see in the strategic framework is the highest position in terms of real trusted comms. So I just wanted to finish up on that point. Thank you.
Okay. Quite a number of directors have contacted me about this paper between the two trusts. So I'd like to pick up on Simon's point about turning this into a comprehensive strategy with metrics. He offered 4 to 5 weeks, Simon. I think we have to say it's 4. It has to come back on the April development session. And we're looking, as Teresa herself said, the teams came together a year ago and she joined us, I think now about 9 months ago. So it does seem to have taken a remarkably long time to get to this point. And in order to restore board confidence in our communications activities, not just in the function, but in our general activities, I think we do need some very harsh and hard-edged metrics about success and performance, both over 3 months and 6 months. And if that comes through, then I think we can hopefully restore the kind of confidence we ought to have, given the investment and the importance. Many people have talked about the role of comms in promoting our clinical strategy, our academic strategy, our discharge programs, our ICAN programs, and everything else. So I think we look forward to seeing the comprehensive report on the metrics in the April development session, and then looking quite carefully at the performance against those metrics through 3 and 6 months and onwards. Thank you for that. Group People Plan Report and Spotlight on Volunteers. Mark, still you. And sorry to have to say we're again a bit behind time here, so I'd be grateful if you could try and keep it this crisp.
Absolutely, not a problem. Thank you, Alan. So I have a presentation. I will go through it very quickly because I'm conscious that this has already been to a number of forums over the course of the last month that's been referenced in CPC and our People Committee, and also shared more widely too. So, and what's really important, I should welcome Emma, who I see has now joined us, who will talk through our volunteers' particular aspect. So if I could go through the slides. Thank you very much, Kieran, if I could take the first one. So our people plan, literally almost a year to the day, I arrived here at the board meeting to share our people plan, and we approved said plan with a number of pledges, 7 of them, as to what we could do within our group to enhance the experience of colleagues working in both hospitals. There was a number of deliverables centered around that particular plan in terms of what we would deliver by when, and a number of measurements that we wish to use, such as the group people pulse survey, and of course our national staff survey. And the people pulse survey has been undertaken and was undertaken in September and again in January, and will be undertaken again at the end of this week in April, which is really starting to give us a good indication as to how people feel working within the hospital, but also things that we can do about it. And it gives us much more real-time information. The national survey results, which are great, we've got them out today. They're not great, but we're good to have them today. But it's November is when people made those comments, and there's something about how we can react in more real time to make some changes and improvements is really important with the People Pulse survey. And we also know to support the full implementation of the plan, we were looking to realign our People Services Directorate, which is really important. Similar to that, also referenced from the Digital Directorate earlier in the meeting this morning. If I could take the next slide, please, Kieran. This is just the 7 pledges. These are obviously really important, and we're appointing heads of service to each of those pledges at the moment, Emma being the one for volunteers, obviously. And these are just a reminder for colleagues. I'm mindful of time, so I'll move on to the next slide. And the next slide, it's gone slightly strange on my screen, but the next slide details around, okay, so where are we a year on? So in the first 6 months, as I came here in September, I think it's important that it was categorized that we had done quite a lot of work around health and wellbeing and diversity and inclusion in terms of trying to move our positions from where they were previously to a more improved position in the future. We also made a commitment within our plans to grow our number of volunteers, which we'll come on to very shortly, and to enhance our international nurse recruitment program specifically to bring more colleagues in to help close those vacancy gaps and help to provide people, again, more time and less firefighting, if you like, on a mitigation perspective around staffing. So in this last 6 months, there were some highlights here that are in the boxes that you see in front of you on the presentation with regards to what we've been able to achieve in that time period. So international nurse recruitment, which obviously has again been referenced at our People Committee, we're above target on that position. So we have 287 colleagues that will join us by the end of this month, in the couple, tomorrow. And you can see the split there with 103 of those colleagues joining us here in Northampton, which we've correspondingly then seen with a decrease in our vacancy rate in our nursing colleagues, of course. We have grown our volunteers, and we'll come on to that shortly. And we have also continued to support our collaboration, so particularly in regards to cardiology, that we know is our next step around some OD work that we need to do as we help those services come together and work collaboratively. That has been in place too. There's some process stuff that we have been able to achieve in terms of the employment contract for Agenda for Change staff, just to spell out AFC. Is that where we previously have, I don't know, section 14 of our contracts, they are now consistent across Northampton and Kettering, that they both relate to the same thing, as opposed to previously where they, again, I think you said it earlier, Alan, it's amazing how 2 hospitals do the same sorts of things, but in slightly different ways. And we're just trying to create some consistency around that, particularly with the employment documentation for colleagues. And as I said, in the bottom right-hand corner here, we've also launched our people leadership team review, including, it's just like which ones you leave out, that we now have access to payslips and so on and so forth online in Northampton, whereas we didn't have that in situ previously. If I could take the next slide, please, Kieran. We have here a video. We've got the link here. I'm not proposing to, it started, but I'm not proposing to go through this now for ourselves this afternoon. It's a fantastic video. This lady who we can see on the screen is a lady called Val, who was a volunteer with us in Northampton General and has subsequently gone on to take a career within the hospital. And that's something that we really want to work upon. And Emma will talk to us about that shortly too. The video also outlines Josie's story. And Josie has joined us as the liaison, if you like, for volunteers under the age of 24, and is working closely with the schools across our county as well, in terms of how we can encourage more people to come in and experience volunteering in our organisation, and really get a good understanding as to what it is that we do in the hospital. I think traditionally, and certainly when I was at school, you've perceived the hospital to be doctors and nurses, which of course is true, and large staff groups that we have as colleagues, but there's so many other services that we provide by a myriad of other staff groups and colleagues too, and it's really important we're able to showcase all of their talent and demonstrate that as well. If I could take the next slide, please, Kieran. Thank you. So our context over Q4 and Q3 and Q4. So since I last came to the board in September to share an update, we know this, we've discussed it here. We obviously had in September the rollout of the booster jab. It seems like, honestly, it seems like years ago, but it was only September when we were asked to increase our booster jab rollout or to start it. And it's really important for us to continue to remember, as Northampton General Hospital, we are the lead employer for the county's vaccination centre. So really playing our part in the system and making sure that we have colleagues able to jab people when they need them. We then had the Omicron wave, which has caused, and obviously caused, as you can see in our statistics and metrics, higher levels of absence and unavailability during the end of December, January time. That really spiked and really caused us a number of concerns, which again have been discussed earlier today, with regards to having to mitigate staff in absence and supporting an increased number of patients. It was a real challenge and applied real pressure to colleagues across our hospital. And then finally, the vaccination as a condition of deployment legislation, which I came to our board around in January. And as you can see in the Quality Committee report that I attended on Friday, and indeed the People Committee on Monday, the revocation, I think that's a proper word, the revocation of this legislation in terms of this legislation being revoked. That being said, as we know, and we documented and reported in our board meeting in January, this is a hugely emotive topic that's taken a huge amount of work to make sure that we communicated and spoke to people in a fair and reasonable manner with regards to this hugely emotive topic in terms of vaccination status. It's something we hadn't implemented before, but it's something that we went through, and I feel that we handled that in a very sensitive way. But we had to align a lot of resource to it. Moving on to the final aspects here, we increased our SOS support, which we've talked about again also today, and we reintroduced free meals to support colleagues in both hospitals, obviously in Northampton, to make sure that people were being well looked after given the additional pressures that they were facing. And we've also talked about in the metrics earlier today the impacts that the last couple of months have had on our development metrics, and particularly that of appraisal and statutory mandatory training. They're really important. They're essential basics, I would suggest, from an employment relationship that we should have in place for colleagues across the hospital. And they really are what sets us apart as an NHS in terms of our ability to offer people a career and development in their role, in their caring role, to really move on in where they wish to be in life. You know, I was reflecting when I wrote this that I started in a TB clinic in the Middlesex Hospital in 2004, and here I am today as a Chief People Officer across 2 hospitals. And that's the development that the NHS afforded me, and we need to make sure we're able to afford that to colleagues in hospitals too. And finally here, during this period of time, we also worked closely with staff side colleagues with regards to the transformational change that we wish to put in place, particularly that of consistency across both hospitals of, as I say, terms and conditions and policies and so on and so forth. And we were able to address some capacity concerns. If I could take the final slide, please, Kieran. So where that leads us to now, he says, waiting for the slide. Here we are. So where that leads us to now in terms of moving forward with the people plan. One of the things that I'm really encouraged to be able to report to the board is that tomorrow we have our first trade union staff side meeting across the group. Given those concerns that we've addressed earlier in the presentation. And in that meeting, we are taking forward the Memorandum of Understanding, allowing colleagues to work between both hospitals without the additional bureaucracy or paperwork that historically we would have needed to have in place. So we don't need to take any more pints of blood from people's arms or any more DBS checks and so on and so forth. We can trust that if one hospital is undertaking all the relevant and standard pre-employment checks and employment checks that we need to have in place, then they can be transferred when colleagues work between one site and the other. And that's all obviously enable further collaboration and making it easier for colleagues to work between both hospitals. That also includes a number of governance and IG situations too. So the transferring of data will also be able to be more freely moved between hospitals. We'll continue to work in partnership, which is here in people partnering and particularly looking at policies. So again, tomorrow, we really set out our stall as to these are the policies that are the most well used in the organisation, if that's the best way to phrase it. And we will work through to ensure that they're consistent. So we don't end up when you work in one hospital or another, their inconsistencies in approaches or policies will make those the same. Denise called upon the collaborative bank earlier in the meeting this morning, and this is something that we are able to put in place to enable that colleagues in both hospitals can work again between both sites. But as Denise equally pointed out, there's just some rates of pay elements that we need to resolve, and they're not, it's easy to say, but they're quite tricky to do because they will involve risk and mitigation on both sites and both hospitals. We need to we have leadership and management development programs in place, but we know that we need to take a look at these once more. Do people have the time to attend them? Is the content of them what we need it to be? That's going to be really important for us to refresh and review in this very short period of time, in the next couple of weeks, not months. And the appraisal process too. So we've had dedicated to excellence in our strategy and priorities and values in place since the summer of last year, and we really need now to embed these. And one of the best ways to do that is with our new appraisal process. So now that we have our head of service in place for people development, that will be one of her first tasks in order to make sure that they are consistent across the hospitals and to make sure that we have people that are working towards our 5 priorities and indeed are respecting our 5 values. A focus on OD and inclusion around reward, recognition and respect. Again, listening to what people have told us in our staff survey position and how do we do that. There's, as I said, there's some corporate things that we definitely can do, but there's very much a number of local things that we can do too to support colleagues further. And finally, in the bottom right hand corner here, one of the things that's lit up my emails and all sorts of social media this morning has been with regards to benefits for colleagues. So this is obviously in response to the news around car parking, which Simon referenced this morning. Lots of CPOs reaching out to one another to ascertain what it is that colleagues are doing across the country. But I think there's a real opportunity here for us to be able to articulate what the benefits of working in Northampton General Hospital are, and how do we inform people of those, both as an attraction perspective in terms of encouraging people to work with us, but also from a retention perspective to keep people continuing to work with us. I think some of those have not been able to be well utilised in the last couple of years, but you know, I don't know many hospitals that have a swimming pool within their grounds that people could use at a vastly discounted rate. We do have that in Northampton, and we need to make sure that we're accentuating those positives, our close proximity to the university and so on and so forth. We need to really be able to demonstrate the benefits of working here in NGH. So that's the presentation from my perspective in terms of the people plan so far. I was going to lead straight into Emma's presentation, if that's okay, Chair, along with the video around what our volunteers are doing for us here in Northampton Hospital. Over to you, Emma, and welcome.
Hi everyone, for those of you who don't know me, I am Emma Wimpress. I am our Group Head of Volunteer Services. Can I have the next slide please, Kieran? So as Mark mentioned, volunteer services now falls under HR, and we're now part of the people plan. So our pledges across the group, so not just for Northampton General, they are for both, are to standardise good practice across the group, to develop consistency in approach to our volunteer utilisation, and to grow our volunteer services to be representative of our local community. So what do these all mean? In terms of standardising good practice across the group, we want to ensure we're offering our volunteers, most importantly, the same experience on both sites, which equally will then have an impact on our patients. This is making sure that our governance is the same, making sure that the roles on offer are the same to both sets of volunteers, and to ensure that all are given the same training and opportunities as each other. This will then lead us in to be able to have cross-site volunteering, which is really important. developing consistency in our approach to volunteer utilisation. So Northampton for the last few years has always had a really good consistent approach in terms of clinical and non-clinical areas, and it's been really important to see that grow, and it's been good to work with our clinical colleagues and our non-clinical colleagues. We want to make sure that we continue to do that, and as a group that opportunities are available on both sites to benefit both our staff and our patients. But I think for me most importantly is number 3. We as a hospital are really representative of our local population. The patients that we have are representative. So actually our volunteer services needs to replicate that and ensure that we are, we have a different diverse opportunity for everybody. Our volunteers are from different backgrounds. We're not just targeting those privileged areas, we're working with those harder to reach groups. So as a group, those are our pledges and what we aspire to achieve over the next coming couple of years. Can I have the next slide, please? So if we just focus on Northampton General Hospitals, we currently have 440 active volunteers. So what we mean by active, that means they are actively committing a minimum of 3 hours each week to volunteering on site, and they don't volunteer off site, they're all on site, and that actually equates to 27.8 full-time equivalent staffs working full-time. So I actually think that is a significant achievement. Throughout the pandemic, we did reach probably 390, 400 volunteers, and we were very fortunate to have those on furlough, those sort of not able to go into work. So the number has recently fluctuated, but we are mindful that with a higher number of under 25s volunteering, that we do tend to lose people quite frequently to going back to their studies, and benefit for the hospital who have gained full-time employment. In addition to the 340 active volunteers that we have a further 112 in clearance, and there are active adverts out. So whilst we know and are mindful that the number is fluctuating, we are very conscious that we can backfill the gaps. And I think it's really interesting to point out that volunteering historically has predominantly been very female orientated across the NHS, and when I talk to colleagues and their volunteer services, but as at NHS we do have 28% of our volunteers who identify as male, which I think is really important, and actually it really shouts about the fantastic work that we've done over the last few months and years to make sure that we are becoming more inclusive and actually more appealing to all sexes, not just to females. Next slide, please. I've talked very briefly about the age of our volunteers. Now, historically, when I started 5 years ago, we were all, bar a few, over 65. We predominantly were a middle class, white, female background of volunteers. So I'm really proud to shout that we are now 46% of our volunteers fall under 25, which is a phenomenal achievement, and also fits in really well with the other people pledges, because these will be our next generation of staff for volunteer, not for volunteer services, for the hospital, sorry. 5 years ago, it was very, very different, and we are continuing to work really hard. With having Josie on board, who is our youth coordinator, we are confident that we have the foundations and the strong relationships with local schools and colleges to sort of churn year on year with the young volunteers coming in. So we now know we need to focus on different age groups, and that's something that we're working really hard to do. So whilst the number of 46% is really good, we don't want to just be underpinned by having youth volunteers in, because we know having school holidays and there's exam periods, there's mock exams, we know that as a service we take a hit with having so many young people. And as Mark mentioned, when we do our talks, we really home in on the fact that we aren't just about becoming a doctor and a nurse. There are people who are finance directors, people who want to become CEOs, people aspiring to be other things. And it's stepping away from that niche that hospitals is just about doctors and nurses. It's so much broader than that. And I will cover that in a further slide. So can I go on to the next slide, please, Kieran? Just to continue the theme of making sure that we are representative of our local community. Again, when I started, I touched on that we were really predominantly white-based group of volunteers. And if you step away from that now, we are moving towards having a much more representative of Black and Asian volunteers. I know we are predominantly still white, however, over the last year or so, we have seen an increase, and that is from the team working tirelessly to promote and actively seek areas and those harder to reach areas and those places that we need to continue to promote. And actually the volunteers striving and shouting about the great work they're doing is encouraging people of not only from different ethnicities, but from less privileged backgrounds, from those who are seeking job seekers allowance, from those who have been out of work for a long time. So whilst we are sort of just talked about our ethnicity and age, it's really important to us that we are inclusive service and the opportunities that we have available are open to all. Can I have the next slide, please, Kieran? So as I talked about, when we go to our talks, we mentioned that it's not just about doctors and nurses. I'll just look at the execs on the calls. There are people who strive to be the next CEO, who strive to be a finance manager, who want to be an OT. There's loads of different things. So our volunteers make up a vast sort of difference in what we do in terms of our work. So we have a response role at the moment. So for those of you who are on site, the response are the runners who will take ad hoc requests. It could be delivering squash to peds. It could be collecting bereaved notes to make sure that our patients' families are getting the death certificate sooner rather than later. So we are really, really conscious that we have a wide variety of services available, not only to our volunteers, but continue to make a difference and enhance both our patient experience and our staff wellbeing. We are predominantly high on our wards and clinics, but I think, as you know, we have a high number of volunteers in these areas, and they are really making a difference to our patient experience. Wards and clinic volunteers will do things such as feeding when they have been fully trained. They will make beds again with full training, but it's really making sure that our volunteers are actually being an asset to the staff and kind of making a real difference and helping our staff with the work that they do and giving them their time to make sure that they are treating the staff and doing what they need to do as our clinical colleagues. Can I have the next slide, please, Kieran? Okay, so I've talked roughly about what our volunteers do, but I think there was no better way than to showcase with a short video. So I welcome you to watch the short video of our volunteers.
With their red shirts, it's easy to spot the volunteers from University Hospitals of Northamptonshire. Answering the phone is David, who wants to make sure everyone has a warm welcome and a great experience on site. In the office, coordinating everything is Josie. She's a key part of the team, making sure all roles are covered and that all departments' needs are met throughout the day. One of the most critical roles is pharmacy runner, making sure patients get their medication as soon as possible. The support the volunteers provide leaves clinical staff free to devote their time and attention to their duties on the wards. Pharmacy runners have an active shift, clocking up as many as 10,000 steps in 3 hours. The new Brew Buddy service is there for hospital staff. Volunteers visit clinical and non-clinical areas to offer staff a hot drink. It's been incredibly well received by all the teams. The aim is for Brew Buddy to visit them twice a week. The local community has been generous with their donations, and the volunteers love performing this role. The buggy service is there for visitors and outpatients to help them get around. Now it's easier to visit the hospital. The buggy is making around 30 journeys every day. It's part of the meet and greet service, which helps outpatients get to their appointment, then brings them back to their drop-off point. The service is appreciated by patients with anxiety and other mental health problems, making it easy for them to get the care they need. Another very active role is working on the response teams. Carol's shift is always varied, collecting swabs and bereaved notes, sitting with anxious patients, even delivering pizzas. This is another way in which the volunteers free up time for the clinical staff, so they can keep doing what they do best. Our ward buddies are there to support our patients, offering them companionship and even making sure relatives can stay in touch by helping them to make and receive video calls. Our hard-working volunteers make a huge difference to the lives of clinical staff and patients every day. They're at the heart of the hospital and our NHS.
Thanks, Kieran. If I can have the next slide, please. Our volunteers always aim to make a difference to both our patients and our staff. And I just wanted to take a moment just to reflect on something that had happened. As I always say, that it's the little things that the volunteers do that really can make a really big impression and have a lasting impression on our families. So I know you've probably taken the time to read this, but a few weeks ago, we were contacted by our palliative care team, and sadly there was a patient who was in ED and he was quite close to end of life. And they contacted the team to see if there was anything that we could do as an anniversary gift for him to give his wife. So the team thought very quickly, and they contacted one of the local flower shops, and we were able to provide a beautiful bunch of flowers for the husband to give his wife. And it made such a difference, and we've been contacted by the family and the palliative care team to really show that just a very, very small thing that took maybe an hour of someone's day from the team to do made such a difference, and really made a really lasting impression to the husband, and he was at peace knowing that he was able to do that for his wife. Can I have the next slide, please, Kieran? So we continue to get feedback, because people often wonder, how do we make sure that our volunteers are doing the things that our patients and staff need? So we continue to get feedback, and that is by all different ways, such as working with our patient experience team, working with our friends and family tests to make sure that we are getting the valuable information that strives us to make sure our initiatives that we're implementing are the ones that are at the heart of making a difference, and we will continue to do so. Next slide, please, Kieran. For those of you on Twitter, we have a large following on Twitter, and we're often promoting that. Our work, we work quite closely with colleagues nationally, and Twitter is a really good opportunity again for our senior staff and staff of all levels to give their feedback. So you'll see from some of the comments of our staff at NGH, the difference actually the brew buddy had made. Michelle talks about as a ray of sunshine, and those things are really important, because I'm a strong believer if we can make a difference to our staff well-being, naturally that will have a really big impact on our patients' well-being. Can I have the next slide, please? Okay, so what works well for us at NGH? So we have a dedicated volunteer hub. For those who haven't visited, we've just been refurbished and it is beautiful, so I welcome you to visit. It is a safe space for our volunteers to come. We've been working very closely with MenCap, and actually having a dedicated area and that safe space, a time to reflect, works really well with our volunteers, and it's a place that we're really proud of, and we're humbled that we've got this dedicated area. I have to thank our execs that are on the call, because without them being the advocates that they are for volunteering, we wouldn't be where we are today. They are an advocate for volunteers, our executive team support. And recently, Heidi has had one of our MenCap learners with her, and that is brilliant. It showcases that volunteering isn't just in our clinical areas, it is for everywhere. And in terms of our community engagement, because our relationship with MenCap is going really well, we're hoping to replicate that with other local organisations, and we've been contacted by people like the DWP to continue to work with those harder to reach groups and those who haven't had a good experience in other sectors with volunteering. And actually our volunteering is meaningful, it's rewarding, and it really makes a difference not only to our staff and our patients, but to the well-being of our volunteers, and that's really important. Northamptonshire Health Charity continues to be incredibly supportive, and they continue to support our initiatives, albeit sometimes they're very wacky initiatives, but they are a big advocate for us, and we wouldn't be able to do what we do without them. And finally, the size of our team is a real plus at Northampton. As we know, volunteering strive and really are proud of what they do, but that is also with the hard work and dedication of my team at Northampton. They do wellbeing checks with our volunteers, they liaise with staff all the time, and without that intel from both the volunteers and staff, we wouldn't be able to do that. And as we grow as a service, we need to continue to remain that size of the team. Next slide, please, Kieran. And these are just some of the pictures that we try to showcase some of the work that we do. You've got the Brew Buddy service there being received. We've got the Pat Dogs, and then you've got the team sort of, I think, on International Women's Day. Can I have the next slide, please? So finally, what are our next steps? So we will continue to increase our number of active volunteers. That is going to fluctuate again with a high level of young volunteers. But if we are aware of that, we know we've got the mitigation in place to make sure that we can backfill as quickly. We'd like to expand our response role to make sure we're more inclusive of clinical roles and freeing up our clinical colleagues to do what they do best. And that we need to make sure that we're shouting about the things that we can do. We need to continue to seek external funding to grow our team, because if we don't have the funding and the staff involved, then we won't be able to grow and won't be able to make a difference. And I think it's really important that we do that. There's loads of different avenues that we can explore to do that. And finally, we would like to, as Mark touched on, formalise the volunteer to career pathway. We're fully aware that this is something that NHS England are looking at, and having had over 50 people previously over the last couple of years who have gained employment at NGH, it's something that we need to continue to do and formalise, not just to be about our healthcare assistants. And as always, our roles will always be underpinned at the patient. The patients are the heart of everything we do, and we will continue to ensure that our roles and the volunteer offering will make a difference to our patients. Next slide, please, Kieran. And that's it from me, and I'm hoping you've had a whistle-stop tour on the great work that the volunteers do, and I'm open to any questions.
Okay, thank you very much, Emma. That was very good and very comprehensive. I'm going to have to deny you questions though, because I'm very conscious of time here, and I know I have some non-execs who have other things to do in the lunch interval. So any questions you have around Emma's work or any other comments you want, can you make them through the People Committee, please, where they'll be picking it up. Thank you very much, Emma. Very impressive whistle-stop tour. Thank you. I'm going to have to go on to the Ockenden review of maternity services now. Mara is there. I think Debbie is introducing her. Yes, there's Mara, Deputy Director of Midwifery. Had the title corrected by Heidi since first thing this morning. And Debbie, over you go. Can I just say here, when Ockenden 1 came out, I asked both boards to ask the question, how do we know our maternity services are safe? Not how do we hope, how do we imagine, but how do we know? Yeah. And that question was answered, I think it was about a year and a bit ago, in relation to the first part of the Ockenden inquiry. Mm-hmm. So that's been an ongoing piece of work, and you can see that in the report by Mara. But now we've got the final, I think it's the final anyway, Ockenden report just come out today. Then I would expect and hope we can come back to the next public board meeting, which will be May, to repeat the answer or renew the answer to the question, how do we know our maternity services are safe? And that certainly gives Mara or some time at least to reflect upon where we are in NGH and compare it with KGH. So I just wanted to put that in context there for everybody. Debbie and Mara, please.
Yeah. So good afternoon, everybody. I'm Mara Tonks. As Alan said, I'm the Deputy Director of Midwifery. So I'm here to update you on our progress a year on from the initial interim Ockenden report. So I'm sure you are all reminded this morning through the national news that the Ockenden review was an independent inquiry into concerns surrounding the maternity services at Talth and Shrewsbury. The inquiry set out to investigate the concerns of initially 23 families, however, has grown to include more than 1,500 families. The final report was published today and has made a series of local actions for Talth and Shrewsbury, but 15 further immediate and essential actions for maternity services that, as Alan said, we will be providing a paper back to board, hopefully around May time, to provide further assurance around the safety of our maternity services within Northamptonshire. So before this report was published today, we had an interim report in 2020, so December 2020, and this was addressing the concerns raised by the first 250 families. The interim report made a series of 7 immediate and essential actions for maternity services to consider. And maternity services at trust level and also through their local maternity and neonatal systems went through an initial assessment process in 2021 to evidence their compliance in relation to the 7 essential and immediate actions. And this also included some workforce actions. So in Northamptonshire, we had no areas of non-compliance against KGH and NGH, and NGH's initial assessment demonstrated an overall compliance of 80%, with the remaining 20% being noted as partially compliant. The assessment process was overseen by our regional perinatal teams, and in January this year, all maternity services trusts were written to again by the Chief Nursing Officer and Chief Operating Officer for NHS England to ensure that a further discussion and reassessment of Ockenden interim compliance was undertaken, and that boards could be demonstrated to boards to give our current position in relation to compliance. Also asked of the Trust Board was for us to note our progress in compliance against the original recommendations from the Kirkup inquiry back in 2015, which was the inquiry into Morecambe Bay. So you'll see from the paper that's been submitted and the appendices that I'm really happy to say that we've made significant progress at NGH, and at an organisational level have implemented all 7 immediate and essential safety actions. We were also asked to update on our workforce requirements. So I brought a separate paper to our Joint People Committee earlier this week, which demonstrated our compliance in achieving all of the workforce elements within the interim Ockenden report. And I also updated members at the Joint People Committee around our current staffing position and the actions and mitigations we have at a local level at NGH to address our current vacancy and felt unavailability, but also noting that this was not unique to Northampton General Hospital, but is across all maternity services in England. So I'm happy to pause there for any questions at the moment.
Ockenden is a big deal. It's clearly a big deal for the NHS. It's a big deal for our patients. Any questions on what Mara said up to now? Jill, as our maternity non-exec director.
Thank you, Chair, and thank you, Mara. Very good, concise presentation. Thank you. Just a comment, really, that at the Quality Committee, we talk about maternity and neonatal services actually extensively. So just to assure the board that this is a topic of high consideration and takes up a large chunk of the agenda, as indeed does other meetings that we all attend, including the maternity and neonatal champion meeting that we hold every month. And I'm really pleased that there was an extensive discussion at the People Committee about the felt vacancy factor that we've been holding here at NGH for more than 6 months, which has had quite a big impact on our workforce. But to give further assurance to the board that there is an action plan in place to mitigate the felt vacancy factor, and also that we have interim measures to assure patient safety. So, for example, our specialist midwives have all taken to the floor to make sure that there is good cover while we're working through sick leave, maternity leave, and so on. So I think we're in a really strong position, and I'd really like to welcome Mara to NGH, because I think there'll be some good learning from KGH and some joining of the dots across the system. So thank you, Mara.
And if I may, if I could just also describe some of the other actions that we've taken, because I think it's important for context. So 2 years ago, we undertook a piece of work with the University of Northampton to increase our student midwifery numbers. So next year in 2020, we'll have double the amount of students, so 100% increase in what we have had in previous years. We're also utilising registered nurses within the service where appropriate. We've welcomed our first international return to midwife, our international return to practice midwife this week at NGH, and we have further starting within the forthcoming weeks. We're adopting a retention midwife in the service to work alongside midwives clinically, especially our new starters, and that's aimed to improve our attrition rates. We have had to make some service alterations in relation to how we deliver services. So we have reduced some of our face-to-face visits within the community, but still making contact with women through telephone triages, telephone consultation, and we've had a reduction in our continuity of carer teams to redeploy teams back into frontline services. one more safety action as well as a system. We meet regularly, well, every day at 12 o'clock to look at the acuity across the system. So that's KGH, NGH, and the local maternity neonatal system to ensure that we can help each other across the system when activity levels are high.
Thanks, Mara. It's good, clear stuff. Denise and then Elena, and then I'll finish up with Debbie and Heidi.
Thanks very much, Chair. I really just wanted to support what Jill said, and also say that we did have a good discussion around this at People Committee. There's a huge recognition of the amount of work that has gone into this. It is recognised that it's a work in progress, and there are still things to be done, but there's a massive amount of thought and a massive amount of work that has gone into it. One of the things that we did talk about in more detail was around the felt staffing vacancy situation, the headroom that we've got written in at the moment, which is different between the two hospitals, and have asked for further information in terms of the sort of financial impact, if you like, of increasing that headroom in order to take account things that are having a big impact on the felt vacancy situations, such as maternity leave. So that's information that we should be getting as well. So lots of work has gone on, as I say, recognised all of the steps that have been taken, and it's definitely a work in progress. Thank you.
Thank you, Elena.
Thank you, Alan. Thank you, Mara, and your colleagues for the work which you're doing day in and day out. And I was fortunate to be able to talk to Mara at the People Committee. The only element which I'm missing is the voice of our patients. We still don't have a metrics, or it's metrics work in progress, percentage of patients who would recommend our maternity services. So I'm really eager to see that metrics, to hear the voice of our users of our services. Thank you.
So just on that, so we absolutely, so we do use the Friends and Family Programme. We absolutely report that through our governance structure within the maternity services. It's something that I will be monitoring monthly moving forward. And as we picked up in the People Committee, we'll also be bringing our maternity service engagement action plan back next to the next People Committee. And that also gives consideration to the improvements we want to make post-publication of our CQC maternity survey.
Thank you, Mara. Final comments, Debbie, and then Heidi, please.
Thank you. I just wanted to give the board assurance, and I know it's been Heidi's priority since she's been in post, and as mine, that we have been asking that question that you ask about how can we ensure that our maternity service is safe. So myself and Mara will definitely be very happy to bring a paper back next time.
Thank you, Heidi.
Just to come back on that same point, Alan, where we've still got the focused oversight from our executive team every week on a Friday. I fully welcome Mara to come and work over here, and supporting Mara by giving it one of my key priorities that Mara will be reporting directly to me, with support from Debbie from a professional perspective and nursing perspective. So this remains a continued focus, and just wanted to assure the board that we welcome the Ogden report coming out today. And there is a lot more we do need to do, Elena, with families, and there's a lot of learning in that. So that's something Mara and I have talked about over and above the Friends and Family test. Our OD piece of work has started, Alan, and is underway.
Okay. Thank you very much. I recommend that our non-exec directors, and particularly obviously the maternity lead ones, read the Ockenden report. It's pretty sobering, but it's important that we read these things. Thank you, Mara. Thank you, Debbie. Look forward to seeing you in May with the comprehensive. This is how we know what our maternity services are safe. But thank you very much for the interim report. It's very concisely delivered. Thank you. Public sector decarbonisation scheme. This is just for the board to note and ratify. I approved after consulting Chair of Audit and Chair of Performance of Finance for this. It is a large amount of money, but we didn't have time to do anything else. And I found it hard to believe that the board would reject £20.6 million worth of decarbonisation. So please ratify that and then pass it to F&P for general oversight, like all other major capital schemes. Are you happy with that? Good, thank you very much. Second point is just for you to note that Richard has completed the Fit and Proper Persons Annual Declaration Review. So following the completion of checks, the board is asked to accept the assurance that all members continue to meet the Fit and Proper Person requirement. Isn't that good? Because it would be a bit of a problem if you didn't. And I don't even think we've had any motoring offences this time. Maybe the roads weren't busy enough to generate motoring offences. You have to declare them. Please remember that. That's that. Thank you. You've noted that. Questions from the public? I don't have any. Any other business? No. Thank you very much indeed. I now ask you to pass the resolution to exclude the public and press by reason of the confidential nature of the business to be transacted. Nods will suffice. Thank you very much. And we will now the next board meeting, next public board meeting will be the 26th of May.